So our flow of program is that Satish will begin. No, he will introduce the concept.
No, Mansi will begin by playing Saraswati Vandana.
Okay. Okay.
Then I'm trying to see if I can put a lamp lighting in that shape. No,
okay.
Mansi will begin by playing Saraswati Vandana.
Okay. Yeah.
Okay.
Yeah.
And then Satish will start.
Yeah.
Then you and Rahul.
Yeah.
And so on.
So we have to do a no. Satish will start, and after Satish, and then my son Rahul is not there. I hope he comes by that.
Coming.
So then I will start. I will briefly introduce Chandrasekhar, and then he will talk. And after that, by the time if Rahul has come, he will introduce Madhusudan, and then we go on. Then question answer. Yeah.
So before you introduce Chandrasekhar, Subhash, you have to give the concept of office neurology. What?
Okay.
In 2 minutes, you have to tell them what you are planning, and that we were going to do a course, but because of COVID, we are doing it online.
Yes. I'll do that. And you will be there all the time, now, Sudhir. You will be there all the time.
I'm around. Yes, I'm around.
Yes.
Sudhir has to be there. We can't go ahead without Sudhir.
Sudhir is the soul. He has to be there all the time.
So it is like heart pumping heart. So if the heart stops, everything will stop.
You can, and Sudhir, you can always come in between, give a comment. I mean, that is fine.
You know, you're talking of soul, Subhash. My granddaughter's name, kya rakha hoga malum hai? It is Ruhi. So it is.
Ruhi. Yeah. Wonderful name, yeah. Wonderful name.
Yeah, very nice.
Yeah. There's a song on that. Ruhi.
Subhash.
KL Cycle Mahmood Rafi. Tell me, sir.
Yeah, Subhash. Sudhir has already started the YouTube, you know. So whatever we speak, it will get recorded.
It's
already started, huh? Okay.
Yeah. It's already started.
Good. But anyway, we are talking nice things only. No problem.
So in between these bands are coming.
Yeah. No, it's quite clear. I'm seeing things clear.
Sir, if you can make me the host.
Yeah, one sec.
So Chandrasekhar.
Yeah.
Your talk is 20 minutes, but you can go 2-3 minutes here. There doesn't matter. But
okay.
How long must be your talk?
20 minutes. 22 minutes.
Yeah.
That's
okay.
I curtailed to that, around that time.
No, we were thinking so that we can take some questions if possible. Otherwise, you can go ahead for even 25 minutes is okay.
Yeah.
If you want.
Okay. Thanks.
But can we take 23 minutes extra?
Yeah. Arey Madhusudan, you are a star, yaar. You are a star.
No, I need only 2 minutes more.
You are a neurology star. Anybody would love to hear you. But it's just as an approximation, we give 20 minutes so that you don't go make it for 40 minutes. That's all.
Okay. Sadish sir, you look a little older today. Aditya sir, you look a little older today. Your mustache has become more grey.
No, you see, Khadilkar is always changing his profile picture periodically. Sometimes you will say, this is called profile. In today's language, it's profile.
Yeah.
So the song for this is Catch Me If You Can.
Yeah. So whenever he gets a new award, which happens very regularly, or some new development, he changes the profile. So congratulations, Satish, for being examiner for this is MRCP neurology or MRCP medicine?
Medicine. It's the same.
Huh?
Yeah, it's the same medicine. Yeah.
Medicine. Yeah.
Yeah, it's 9:58. So shall we start?
They open करून टाकले का मानसी?
नहीं, अजून I think we are still 2 minutes.
It's broadcasting. Now it's broadcasting, so everybody can join.
Clock sharp.
ओपन केलंय ना ते बंद करावी लागेल विंडो तुम्हाला बिकॉज ते बॅकग्राऊंड मध्ये आवाज येतोय.
Who? What?
युट्यूब जिथे तुम्ही स्टार्ट केलं होतं ना, म्हणजे जिथे लाईव्ह स्ट्रीमची विंडो आहे ती म्यूट करावी लागेल किंवा बंद करावी लागेल?
1 minute.
Aru?
Hello, Satish.
Hello.
Hi, Roop.
Hello.
So I
Morning,
have
Roop.
switched it off. I
Hello.
don't have YouTube.
Rahul has come. Good morning, Rahul.
Good morning, sir.
Good morning.
Good morning, everyone.
Acha, Rahul, I will introduce Chandrasekhar. You will also introduce Madhusudan. Is it okay with you?
No, sir, you can introduce both of them. Actually, what we can do is once we start, you tell about this concept of what
Yes.
or next
Yes.
thing.
Yes.
And then let me say we are doing every weekly and we will introduce a program maybe 4 days or 5 days prior. It will go
Okay.
to August, and that's what I will say. Rest everything you can take over because I need to do a quiz also. So you can talk in the first.
Okay, no problem. That would be wonderful. That would be wonderful.
Yeah. So it is 10 o'clock. Shall we start?
Satish
I
is.
think so.
I think we should.
No, Satish.
Just, I think, how many people have joined?
70.
Okay.
That's good enough.
So give it another 2-3 minutes.
Wait for Satish to come now.
Yeah, I'm there, Roop.
Satish is there. Satish.
Okay, but then we start with the condolence. I mean, that we have to start with.
Yeah.
Yeah, hi, Roop.
Hi.
Good morning, Rahul.
Good morning.
So shall we begin?
Yeah.
Yeah. So, ek kam karo. Don't do the Saraswati Vandana. Give me 5 minutes. I'm preparing that thing.
See, I think
so, Satish, you start.
I'll start with Om Saraf
Yeah.
thing. I will
Yes.
say things and then you give the Saraswati one.
Yeah.
Right.
So I'm just preparing that.
Right. So good morning, everyone. Let me welcome all of you to this fine Sunday. I think before we start, there is one thing that we must do, that one of our colleagues, Dr. Om Saraf, was the practicing neurologist in Bombay. Passed away last night and he had the COVID. So for 1 minute, if we can have silence for him and may his soul rest in peace. And let's begin with the today morning seminar. As you know, a little background I'll give you. 2008, Sudhir and Roop, the two musketeers, started the Fine Foundation. They first started with the physicians, and then very quickly they went on to the neurologists. And in 2015, some of us who were already working with them on programs joined them, and the Fine formed a Fine Trust. Now, all these years, Fine has been giving out excellent programs, and the themes have been variable. And over a period, everyone has got the hang of how to get the program together, how to get the best speakers in the world, and how to really give what is required for the neurologist. Because the aim of the Fine Trust is very simple. We tell others what we want to know. So the programs go on getting better and better. And in fact, Roop told me that 2 years ago, Anne Burke, who had come for an epilepsy program, told him, this is the best epilepsy program that she had. And she sat through the program. So that's how the Fine has been moving. Now in March, suddenly, when new programs were being planned by Fine and by everyone, suddenly the COVID came in, everything stopped. We stopped working, we stopped running our OPDs. And that is when Sudhir sort of took the thing in his hand, and through Fine's goodwill and through his own goodwill, got the best speakers in the world. And as you know, in the last 2 months, Sudhir has done 108 webinars since the COVID has started. So I think he deserves a very big clap, and that's a huge achievement. I suppose he could go in some kind of records. So I think 4 to 5 programs were done every day for last so many weeks, and we all enjoyed them. I think a time has come when the lockdown is now closing and we will get back to our lives and we will have things to do in the daily routine. So the fine has decided now that we will concentrate on once in a week, that is Sunday, 10 to 1. And we will have every Sunday a 3-hour program through fine. And there may be occasionally others beyond this time. So basically what we will do is either have a single theme for 3 hours and the lectures will be intertwined, as will be today. Or sometimes there could be standalone 1 hour separate slots. So the first beginning slot is extremely important, which is OPD neurology, which we all do. And this is being done by Subhash Kaul and Rahul Kulkarni. And they have put up a fantastic program for you. So with this, let me hand over to Sudhir for the Saraswati Vandana for the beginning of this new venture of fine, and then to Subhash and Rahul to carry on. Thank you very much.
Mansi, can you play the Saraswati Vandana?
Yes, I'll do that.
Yeah. So traditionally, we have been lighting a lamp and playing the Saraswati Vandana. I was trying to look for an online site where one could click and lamp light, but most of them have some church sites and things like that. So I think we'll have to just give that a go and just listen to the Saraswati Vandana. This has always been Roop's idea that we play the Saraswati Vandana before any of our fine programs. So okay, so with this, I'll hand it to Subhash and Rahul to begin the proceedings.
Yeah, good morning, friends. I welcome you all on behalf of FINE for this series on office practice of neurology. Now, office practice basically means OPD practice. That's the American expression of the OPD practice. And you know, OPD practice forms a very essential part of any practice, but particularly neurology practice. Even patients also prefer OPD treatment. I mean, just imagine a patient coming and you tell him, I have to admit you for 3 days, and then the patients also don't like it. So it is always good if all neurologists are trained in how to deal with a patient who comes to their office. And within that short span of time, they listen to the history, they make an appropriate examination, they make the diagnosis, they order the investigations, call him again review and make a diagnosis. And I think 80 to 90% of our diseases definitely can be managed with office practice, but everybody cannot do a good practice. It needs a lot of knowledge, it needs experience, it needs a certain kind of technique. So, and you know, all diseases, whether it's multiple sclerosis or dementia, even follow-up strokes, everything can be dealt with office practice, including the consultations which we have. So basically, it is a brainchild of Rahul Kulkarni, I can tell you that, because he initially he said that we should have a series, and I joined him. And Rahul is going to tell you about how it all turned out and what's going to be the flow in the ensuing weeks. But we made sure that we take those speakers who have a lot of experience in office practice. So with that, we made this research. In fact, we had planned it as a full-fledged conference. It was supposed to happen from 27th of May, full 2.5-day conference. But because of COVID, we cannot do the physical conference, so we have come into this webinar mode. So I'm sure you're going to enjoy it. So Rahul, can you say further about it, our planning and what's going to come in the weeks to come? You can probably announce the next week also, next week's speakers.
Okay. Thank you, sir. So this is going to be a webinar-based conference, but it's a thematic conference. Typically, like a fine program, it would run over the weeks every Sunday. Every Sunday there will be 2 talks, which will be probably linked to each other. So there will be some coherence between 2 talks. Today it's going to be history taking and the rapid examination, as we see the 2 speakers. Next week it's going to be fit, feints and funny turns part 1. Whereby Dr. Sita Jayalakshmi will be talking about borderlands between fits, feints and funny turns, and our own Roop Gursani will be talking about syncope. So this is how we would be probably announcing, and the conference and the meeting would run till August end. Everything goes well, even if the COVID ends and the lockdown gets up, we are going to continue this. So we start the inaugural meeting. I think I'll hand over to Dr. Kaul to introduce the speakers today.
Well, it's my pleasure to introduce the first speaker of today, whom everybody knows. That is Chandrasekhar Meshram from Nagpur. He runs his brain center in Nagpur. He was president of the Indian Academy of Neurology. He was secretary before that. And I think all neurologists know him because he has been personally interacting with them. And during his time, the academy, he really gave it a flip and he gave it a totally new shape in terms of programs, aims, and objectives. I have first seen Chandrasekhar Meshram in PGI Chandigarh when I joined as a resident. And before I joined him, I saw Dr. Chopra, who was our mentor at that time, during the examination. And one of the other residents told me, look at that man, he's Chandrasekhar Meshram. He's the most brilliant resident here. That is what was my introduction. But one of the main things why we selected Chandrasekhar Meshram today is because Chandrasekhar is one of the few neurologists who right from the beginning has been doing office practice. Right from the beginning, he did not do intensive care. He did not enter. Right from the beginning, he did office practice, and he has been hugely, hugely successful in his office practice. Anybody will tell you that. Anybody will vouch. Even the neurosurgeon Lokender Singh and all told me, who is now president of NSI, that he is way ahead of anybody else while being an office practitioner. So it's my pleasure and an honor to welcome Professor Meshram to give us this talk. And his talk is on history taking, which is very appropriate these days. In these days of COVID, we would rather make our entire diagnosis by history and minimize the examination part. Dr. Chandrasekhar, please.
Thank you, Dr. Subhash. Should I share my screen? Yeah, Dr. Subhash Kaul has been after me for quite some time that I should speak on this topic. I was not very keen because talking to a neurologist on skills of history taking, because all the neurologists are expert in that those skills. And then he said, no, it is about the busy clinic that we have to talk about. So I finally accepted, and thank you, Subhash, for roping me in. I am happy that for this new webinar series that we are starting today, I am the opening batsman.
Yes.
And I don't have a pressure of if I fail or don't perform, because the one down batsman is like Sachin Tendulkar, Dr. Madhusudan. So, when we take up neurology as a career, there are 2 questions which are deeply inscribed on our brain. And what are these questions? That where is the lesion and what is the lesion? Now, once my friend said that, Chandrasekhar, ये जो 2 सवाल है, ये जिंदगी भर पीछा कर रहे हैं. और मुझे एक गाना हमेशा याद आता है, कि तेरे इन मासूम सवालों से परेशान हूं मैं। तो मुझे ऐसा लगता है ये सवालों ने जिंदगी बर्बाद कर दी है। पर ये सवाल मासूम भी नहीं है, बड़े खतरनाक सवाल है। एंड आई टोल्ड हिम दैट जिंदगी बर्बाद नहीं कर दी है, जिंदगी आबाद कर दी है। बिकॉज न्यूरोलॉजिस्ट are the only physician who are in the best position to answer these questions appropriately. So in this topic, the three things are important: skills, history, and busy clinic. Now, why history is important? Because as Dr. Kaul said that on the basis of history only, we can diagnose about 80 to 90% of the patients. And it is more important in the COVID times because we are practicing telemedicine. And then not only that, you have to make a diagnosis because you have to make a correct diagnosis. And for that also history is very important. And because it can save many lives. And while taking history, you should see that your patient is satisfied because the patient is of prime importance. And you should also be satisfied that you have done a proper job. Now, what is busy OPD? Busy OPD means you see about 100 patients or 80 to 100 patients, and there are many of the neurologists who see so many patients. I am one of them. Basically, frankly, honestly, if you ask me that I would not like to see so many patients in a day, but I can't help it. So seeing 100 patients, I call these people as centurions. And then what is the composition of these patients? The majority are 70% are follow-up patients, and new patients are about 30 patients. And what they compose mainly headache, vertigo, stroke, seizures, psychosis, and others. So you shunt out the psychotics to your psychiatric friends, and then you are left with about 24, 25 patients to be seen over about 4 hours. So roughly 6 patients in an hour. So 10 minutes per patient, and some patients would require more time, some would require less time. And sometimes I had to spend about half an hour for difficult patients. So is that time is enough to take a history? Because the survey has shown that the expert clinician forms a notion of what is wrong with the patient within 20 seconds of seeing the patient. And therefore 10 minutes is a good time. Now, what is the rarest commodity in healthcare today is time. So if somebody asks me that I have a very busy clinic, so should I cut down on history taking? And the answer is big no. And Professor Singhal has always concerned that the young doctors usually don't give enough time to the patients. So you have to manage your time properly and manage your assets. So it is a good idea to appoint an assistant to note down history, because that jargon in the history can be taken care of. When the patients enter your clinic, he wants to tell so many things that I have gone to this doctor, then he said this, then I went to the other doctor, then he said this, and so many other things which are not really important from diagnosis point of view. But he wants to tell that to the doctor. Then the investigations are recorded. Someone, if there is who has an acute problem, so you can screen out that he needs to be seen urgently. Then you shunt out to the psychotics to your psychiatric friends with a caveat and the mention that you have not seen the patient. So, and you inform the patient that if needed be, I will see the patient again. And if the patient forgot to tell you something during the interview with the assistant, then he will tell you. And mind you, this is the first filter, and you don't have to depend on his history, and you have to take your own history because that is important for your diagnosis. Now, the clinical skills are acquired through good mentorship, regular training, and in-depth knowledge of the subject. And during your training as a resident, you acquire these skills at the bedside, and they stay with you lifelong. So you should spend most of your time in acquiring these skills, reading about the subject. And the only bed you don't learn from is your own. And I was very fortunate to have these stalwarts to guide me during my PGI days as doing MD in medicine and then DM in neurology. And you can see this Madhu is also there in those stalwarts. And though I learned my academic neurology at PGI, I learned how to apply that knowledge in practice from Professor Singhal during my days with him as Bombay hospitals. Some of the teachers or the physicians, they may not teach you, but then you learn from them by the phenomena catch as cats can process. Now, are the skills of history taking different in a private clinic and in academic institutions? No, the skills are same, but you have to apply your expertise when you are seeing the patients in OPD, and you have to optimize your performance as a clinician. And the skills are usually acquired only after several years of being in medical practice, and I am still in the process of acquiring these skills. So acquiring these skills is a continuous process. And history taking is an art. Listening to the patient, asking and talking to the patient, and feeling for the patient, that is also very important. Sir William Osler, who is considered as father of modern medicine, has said that if you listen to the patient carefully, it tells you the diagnosis. Now, one of my friends said that Osler का क्या जाता है, वो बोलते रहता सुनो सुनो, पर समय कहाँ है इतना सुनने के लिए? So the study was done in United States, where they give fixed appointment for 5-6 patients in a day. And so it was a tape recording was done. And the interviews of doctors and patients while taking the history were recorded. And the findings were quite revealing. The doctors frequently interrupt the patients before they tell their full history. Doctors listen for an average of 16 seconds before breaking in, and some doctors interrupting the patients only within 3 seconds. Less than 2% of the patients completed the story once doctor had interrupted. Now, 25 to 50% of the time, doctor and patient disagreed on the chief complaint itself. 50% patients failed. They had symptoms they were concerned about, but did not have the chance to describe them. So if you interrupt and ask questions, you will get the answer to those questions, but you will not get a proper history. So you have to master the skill of listening. And what are the skills? These are the different skills of listening. And what is important for history taking is reflective listening or emphatic listening. Now, during your residency, you learn a structured history taking. And these are with various components, personal profile, presenting complaints, history of present, etc. And then you go on to a sequence of history, examination, diagnosis. But when you are in practice, the things are different. You'll also learn that histories should be problem focused, detailed, and comprehensive. And in practice, you take a history, brief history, then you move on to examination because you have to manage your time. During the examination, you take the history. And then you can come back to history after the examination. You find something different from what you are suspecting, because on the basis of history, you formulate the hypothesis that what is wrong with the patient. And to substantiate that hypothesis, you examine the patient, ask some questions during examination in relation to that hypothesis, and you come back again. Like if the patient comes with a history of headache, then you move on quickly to see if the fundus, and if he has papilledema, then it rules out all the primary headaches, and then you consider the possibilities of secondary headache. And if it is subacute onset headache, then you have two important possibilities of cerebral venous thrombosis and idiopathic intracranial hypertension. So to diagnose, you should have an in-depth knowledge of the subject. But the knowledge is never ending, and it is very difficult to have all the information about the subject because the new information is coming every day. But with a great knowledge, it is also not important that you have got a good knowledge and you will make the right diagnosis, because it is important to organize and coordinate your thoughts. I remember one of my colleagues during my training in medicine, that he had a excellent knowledge, and but then whenever he's seeing a patient or a difficult patient, like he would search me from somewhere and then says, Chandrasekhar, this is a very interesting patient, can we discuss? And then he would ask me, Chandrasekhar, what do you think the diagnosis? Like if I said, oh, I will show the signs, and he said, it is Wilson's disease. Then he said, now you wait. And he will give me a talk on Wilson's disease for about half an hour. And then he will tell me that how to suspect Wilson disease, how to diagnose Wilson disease. And after 3 months or 2-3 months, if he again gets a patient of Wilson disease, the same story will be repeated. So it is important that you connect the knowledge of the disease with the classical clinical presentation. That is very important. Now, it is also said that eyes cannot see what mind does not know. So, and the Osler had said that we miss more by not seeing than by not knowing. So Osler to picha nahi chhodne wala hai clinical medicine. But it is not important to see what the mind knows. It is also important that you see beyond the what mind does not know. And to see beyond that, one can discover new things and enhance the understanding of our disease. Now you should, when you are sitting in the outdoor, the concentration and attention is very important. So if you have a tussle in the morning with your spouse, then your day is gone. So try to have these interactions later in the day. And the trick of the trade is always keep your waiting room full. If a wife tells or starts asking a lot of questions, the husband would say that don't ask unnecessary questions. Can't you see there are so many patients there in the waiting room to follow? So you must remember your patients and remember your mistakes. Now, I was joined in the medicine and my first posting in neurology. First day, first patient. And I asked, "Kya takleef hai?" And she said, "धक्के लगते हैं." दरअसल और क्या होता है? गिर जाते हैं. And then I examined the patient and took to Dr. Madhusudan. And he said, "Chandrasekhar, this is very interesting patient. This patient has got progressive supranuclear palsy." And I still remember that patient, first day. And you should also remember your mistakes, because you learn from your mistakes and others' mistakes. And it is all about your thinking process. That I gave an oration on thinking in your clinic. It was a presidential oration at Chandigarh in 2014 and highlighted what are the errors that you make in clinical diagnosis and how to overcome these errors. And sometimes you note down, or you should be always in search of interesting phenomena. I was during my residency at PGI, I had seen a girl who had focal seizure, but then the interesting phenomena was that she would rotate anticlockwise 1 or 2 circles and then she would become unconscious, and I had shown to Dr. Prabhakar. And I was possibly not very clear in explaining what the patient had. After 15 days, I saw another patient, and again I told to Dr. Prabhakar, and this time I demonstrated that what this patient was doing, that 1 circle, 2 circles, 3 circles, and then she falls. And then Dr. Prabhakar said, "Oh, Chandrasekhar, this is very interesting." And I said, sometime back I had seen these patients, and over the period of time I collected 7 patients, and then were published in Epilepsy as rotatory seizures. And that time in the world literature, there were only 13 more patients. So you should always be on a lookout for these interesting patients, difficult patients, so that the neurology becomes interesting. Even if you have a busy practice, I have a huge collection of such interesting patients with more than 70 odd patients of PKD and more than 109 patients of CVT and so on. And some of the history is so pathognomonic that if the patient tells that the child laughs during sleep, then you can immediately think that he's having brainstem glioma. And the language is also very important. And again, there is a little bias for the PGI days because Subhash is there, Madhu is there. So I was in medicine OPD. I was in neurology OPD doing medicine that time. And the previous day, I had seen a movie, Nikah. It was a very interesting movie starring Salma Aga, Deepak Parashar, Raj Babbar with famous numbers, Chupke Chupke Raat Din and Dil Ke Arma, Aansuon Mein Beh Gaye. And in the morning, Madhu came to me and asked The name of the movie was Nikah. And Madhu came to me and asked, Chandu, what is Nikah? Then I said, it's marriage. Then he went back. After 5 seconds, he again came back. He said, Chandu, can you come? I asked, I can't figure out what is wrong with the patient. Everything seems to be all right with the patient. So I went there and asked, Babaji, kya takleef hai? He said, Nigah kamjor hai. So that language makes a lot of difference. And whenever you get a chance, you should always try to take the patient, history of the patients in their mother tongue. And it helps a lot, and it makes more comfortable and convey what is wrong with the patient. I can remember this important patient admitted with, again, this is a first patient at Bombay Hospital with Dr. Singhal. And this patient, and I could suspect this patient because this patient was Punjabi, and as the patient was unconscious, and I could get a history from his wife, his mother, his father in Punjabi. And then because diagnosing this patient was nothing great, and I suspected this patient could be having compressive myelopathy. This was in pre-MRI era. He was investigated, operated, because he had Arnavchari malformation with syringomyelia, syringobulbia, and he went on walking. Then I saw a patient in outdoor recently with history of seizures. Then he was taken to a corporate hospital. There he had another seizure. And then he was investigated with blood test, EEG, MRI, everything. And because he had another seizure there, it was generalized seizures. And he was labeled as seizure disorder and asked to continue the treatment for 3 years. And he came to me for second opinion. So whenever you get a single phenomena, it is a good practice to start with a chronology and start what happened since the patient woke up in the morning. So he had seizures about at 1:32. And this patient, because sometimes the patient will not tell you because they think that that information is not important. But that can be a clue to a diagnosis. And then I asked that what he did after he woke up, then what happened. And then finally, in the afternoon, he said that he was having pain in abdomen and his grandmother gave him camphor. And after 15-20 minutes, he has seizures. So I asked that, did you not tell the doctors there that he was given camphor? Then he said, nobody asked me that. So it was a camphor-induced seizures, and same is true about the gas geyser seizures. So if you don't ask the history, you may not get the history. And sometimes you have to act like a detective. Like once I was called to see a patient at the night, 12 o'clock in the midnight. It was a wedding going on. And the wedding reception was over, and my friend called me that, Chandrasekhar, please do a favor. Please come with me to see a patient. The bride has some neurological problem and marriage is about to break out. And then I went there. I thought that it is a drug-induced dyskinesia. And I asked people whether she's taking some medicines, and then said, no, she's not taking any medicine. I asked repeatedly, but I was sure it was drug-induced dyskinesia. And then I asked repeatedly. So then I called her brother, younger brother. I said that, तुम्हारे बहन की शादी टूट जाएगी, बताओ सच क्या है? So he said, no medicine. Then I poked him. So he said, yes, she is taking medicines for prolonging the menses. And he got the medicine and the prescription. The doctor had prescribed regesterone and she was taking risperidone. And you should be always on a lookout and visualize some interesting patients. Like a good footballer like Messi, visualize that there is a possibility of goal even in the difficult situation. And when you are in fixed that you don't know what is going wrong, you should always buy the time and think about it again and think later on. This patient, again of pre-MRI era, had sudden onset occipital headache and neck pain for 2 days, history of unconsciousness, was found to have neck stiffness at the local hospital, diagnosed as subarachnoid hemorrhage. CSF was done uniformly hemorrhagic, and diagnosis of subarachnoid hemorrhage was established and referred to higher centers. She had neck stiffness, cranial nerves normal, quadriplegia, CT scan normal, 4-vessel angio. So there were two problems. What is the cause of subarachnoid hemorrhage and how to explain the quadriparesis? So when you are in fix, you go back to history again and again and again. And what was the real story? That while putting the clothes for drying, she had neck extension. She did neck extension. She had vertigo, fall, sustained neck injury, developed fractured spine, dural tear, blood in the subarachnoid space. And while doing lumbar puncture, the neck flexion due to subluxation of C3 over C4, she developed myelopathy leading to quadriplegia. In fact, the patient never lost consciousness. The limb became weak, and she said कि हाथ पैर बेहोश हो गए, मैं बेहोश नहीं हो गई. So sometimes the patient, what he is meaning, the symptoms, the actual meaning may be different. And some of these common symptoms like weakness, dizziness, blackout, numbness may have different meaning for different patients. Once in a OPD, the patient came to me and he's saying that he is having loose motions. I said, since when? Since morning. I said, what do you mean by that? He said that there are no motions on the right side of my body. So therefore, the people are ignorant. There are many people are uneducated. Therefore, it is very important that you should educate the patient, and therefore the public education activities are very important. And whenever we do some education activities on epilepsy, we demonstrate the seizures on TV or in public meetings, and patient sometimes comes with complex partial seizures missed by doctors and says that it is the fourth one in your video that I am having a problem.
Chandrasekhar, please wrap up quickly.
Yeah, sure.
Thank you.
So
The talk is going on extremely well, but because of time limitation.
This is 25 years male with fever, headache. For 2 days, his CSF was suggestive of pyogenic meningitis. Repeat CSF was done. After 7 days of antibiotic course, the patient was all right within 1 day, but then the CSF was abnormal, still abnormal. So again, go back to the history, and when I went back to the history, then I discovered that the patient was sleeping with the dog for last 1 month, and which was a new thing to me. And then we sent his CSF for brucella. It was strongly positive, and the patient was recovered. So whenever you are in fix, go back to history again and again. So to improve your clinical diagnosis, listen carefully, question properly, observe keenly, think deeply, independently, differently, and creatively. And it is history, history, and history. So during my internship, I had gone for a residential camp at Anandvan, which is Baba Amte's dream project, which deals with leprosy, care of leprosy patients, and their rehabilitation. And it is the largest NGO in the world. Fortunately, presently, I am the trustee of that NGO. But when during that internship, I interacted, my first interaction with Baba Amte's son, Dr. Vikas Amte. And then I asked him that, is that a hospital? He said, no, that is not a hospital. He said, I saw some patients lying there. He said, they are not patients. They are human beings like you and me. And we are there because they are. Thank you very much. And that was an important lesson to learn.
Thank you. Thank you. Thank you. Thank you, Dr. Chandrasekhar. I think now we know what is the success behind your such a successful practice in the last 2 decades. You are as brilliant today as you were in PGI. Thank you so much. Now, we'll not have any questions and answers. We are running behind the schedule. In fact, in these webinars, most of the webinars which I have been seeing of FINE or others, they always run behind the schedule. But the talks are very interesting, I must confess. Thank you so much. Now, it's my, again, pleasant duty to invite Professor Madhusudan. Dr. Madhusudan, beyond any doubt, is now the most acknowledged and successful teacher, neurology teacher who is very much in demand. You know, all of us are teachers, but Madhu is something different. If you ask somebody who is the best teacher in neurology in America, they will say Samuel Martin. And if you ask somebody who is the most in demand teacher in India, I think without any doubt, people will say Madhusudan. So, you know, in the filmy language, like they say, Kuli number 1, hero number 1, Madhu is teacher number 1. So over to you, Madhu. And I would request you to try to stay within 20 minutes. You can take 2 minutes extra. And one thing is there, in these days of COVID, we want minimalistic examination with the patient. So keeping that in view, please, I invite you to give your lecture to us. Focused neurological examination in an OPD setting. OPD word is important. Okay. Over to Madhu. Madhusudan.
Thank you, Subhash Kabul, for your kind words. What I have been asked to talk to you is the focused neurological exam. Are you able to see my?
Yes.
Slide?
Yes. Please put it full screen.
Yeah, right.
Slideshow.
Yeah.
But your voice is very low.
Pardon?
Your voice is low.
Voice is not coming clear.
Yeah, are you able to hear me now?
Yes,
Yeah,
yes.
yeah.
Thank you. The history and physical examination are both indispensable, as you know, and mutually complementary elements of neurological examination, as all of you know. However, it is not necessary to take a detailed history and a neurological examination in each and every case. What you need to have a relevant history and a targeted and focused examination. The neurological examination can be broadly divided into 2 categories. One is a complete examination, which is detailed and comprehensive. The other is a focused examination. What is meant by that is that this is an examination that is tailored based on history, and clinical suspicions based on history. And it is detailed in areas deemed clinically relevant, but may completely omit parts of the examination deemed to be irrelevant. See, most of you are DM examiners and you expect your student to do a complete examination. May I ask, how many of you are doing the same in your practice? Hardly none. We are not practicing what we teach or preach. Putting in other words, we are all doing focused examination in some way or other. Why do you want focused neurological examination? As Chandu has rightly said, the most important precious thing for the doctor is time. What neurological examinations do depends upon what you suspect in the history, as amply elicited or explained by Dr. Chandrasekhar in his previous talk. Let me give you one example. Imagine your patient comes with weakness of lower limbs and unable to walk. Here, examination of the smile becomes irrelevant. On the contrary, examination of the perianal sensory loss becomes relevant. Imagine a patient comes with left hemiparesis. Will you examine each and every muscle on the left side? No. On the other hand, if it's an LML lesion, we do individual muscle examination because we want to localize the lesion on the root of the nerve. In general, based on the history, one generates or prioritizes various hypotheses, followed by a focused physical examination. To quote one example, a 70-year-old patient from a poor socioeconomic background comes to you with radiating pain along the back of the left lower limb for the last 2 weeks, following lifting up a heavy weight. You decided to do a complete examination. Until the complete examination findings, eye function showed impaired recall. Eye examination showed mild facial droop on the left side. Motor examination tone was normal in the upper and lower limb. There is weakness of left extensor hallucis longus as expected. The rest of the muscles are normal. Our deep tendon reflex examination showed left triceps reflex was absent. Rest of the reflex are all normal. Plantas were indefinite or Korea upgoing. I'm not sure whether it's upgoing or indefinite. Neither upgoing or downgoing. SLR was positive on the left side. What will you do in this patient? Will you ask for MRI of the brain, MRI of the cervical spine or lumbar spine, or a whole MRI, or none? What will be your choice? Some of you may want an MRI of all the parts. Of course, you have got a justification. MRI of the brain to find out the cause of the facial droop and Korea upgoing planta, or MRI of cervical spine because he picked up left triceps was absent and suspicious upgoing planta, and MRI LS spine to find out the cause of this pain in the left leg. Okay, if you order them, you know what is going to happen. He will agree and simply disappear. That is what is going to happen to my patient if I am working here in Trivandrum. Most of us probably will ask for MRI of the lumbar spine, screening of the cervical spine, and MRI was taken. Okay, the MRI showed cervical spine, cervical disc protrusion at C5, C6, C6, C7 with mild compression of the cord, but without any signal changes in the cord. MRI LS spine shows bilateral root canal stenosis at L4, L5, L5, S1 level with disc bulges at L3, L4, L4, L5, multiple levels. MRI brain shows diffuse cortical atrophy and age-related subcortical microvascular ischemic changes. And what will you do now? Every investigation showed some abnormality. Do you advise surgery for the lumbar spine followed by surgery of the neck? Obviously no. What I would do in my practice, I will confine my examination only to the lower limbs first. I will not do complete examination. If there is no findings, that is what we usually find in such a case with the root pain along the left lower limb, or at most the weakness of the left EHL, I will treat him as a lumbar disc prolapse and follow up and do no investigation. On the contrary, if the upgoing plantar is still more definite or more suspicious, then I will try to do the further examination to localize the pyramidal lesion where it is in the patient. If there is no evidence of any pyramidal lesion like weakness or spasticity, I will not chase the upgoing plantar or the wavering plantar and keep him only under follow-up. Here again, I will not do any further investigation. Treat him as a case of disc prolapse and follow-up conservatively. You may ask me why I did not chase the facial droop or the absent triceps reflex and upgoing plantar. At present, I do not know whether the cause of the bilateral upgoing plantar is cervical spondylotic myelopathy or a multi-infarct state or not. Most likely, it's an unrelated cervical spondylotic myelopathy in view of his absent triceps. Whatever it is not the problem for which he came. I'll treat him as for what he came and keep him under follow-up. On the other hand, the patient is an affluent one. I may tell him that, or inquisitive one, I will tell him that there is one finding, the cause of which I do not know, but that finding is nothing to do with your present problem. Certain investigation may help to find out the cause. The most common cause of that unrelated upgoing plantar in this age group is cervical spondylotic myelopathy. I may suggest that possibility. If he is not willing for further investigation, I will not keep him. I will keep him only follow-up. I will not insist on MRI. Unless I think that's a sinister condition, I will insist on MRI. But in this scenario, I will not press him to get an MRI on the cervical spine or brain. In this case scenario, I may do an MRI of the LS spine. In the first instance, in certain patients, that is, the patient is very apprehensive to know for certain what is condition. Some people are like that. so-called doubting Thomas, like they don't believe you. Here, the opinions may differ. Legal practice is largely an individualized one. Nobody can find fault with your decision or my decision. Suppose my patient comes back after 2 weeks with no relief, with bed rest and conservative treatment. Then what will you do at that point of time? Then I would plan an MRI of the LS spine. Let us see the MRI findings, review the findings once again. Same findings, canal stenosis bilaterally and multiple disc at multiple level. Now, what do you think? What do you do at this point of time? If you think that the lesion in the spine is very insignificant and cannot explain the findings in the patient, then think of an alternative cause for his radiating pain, like prosopagnosia side neuropathy. So in this case scenario, I feel that MRI finding cannot explain the findings. I do not find a particular lesion to account for his left L5 radiculopathy, which I found by history and examination. So what will you do now? I'll go back, re-examine him, and look for findings which might have not looked earlier. I might not have looked earlier. So for example, looking for the weakness of the hip abductors, which I might not have concentrated on the previous examination. We're doing a Trendelenburg test. Because as you know, presence or absence of weakness here, hip abductors can differentiate prosopagnosia from sciatic neuropathy. I will ask for an NCS as well as repeat MRI to concentrate on lumbar plexus and sciatic nerve. I feel that most of us would do the same in all our practice. That means we're all doing focused neurologic examination in some way or other. Now, what is the problem in doing a complete examination? It is not practical. It is very time consuming and may not bring the desired result. Moreover, you may pick up some unrelated finding as in the case scenario which are projected. And in an effort to find out the cause, you may do many investigations which ultimately lead you nowhere, ultimately resulting in confusion, not only for you, but for the patient as well. I have seen patients being operated for cervical disc prolapse for a patient with lumbar radiculopathy. Since MRI finding reveal a large disc lesion in the cervical region and a minor symptomatic disc lesion in the lumbar spine, the same thing vice versa also has happened. So one must always think whether the finding in the MRI can explain the patient's complaint. Some cases, however, the focused examination will not work. You may be forced to do a complete examination. This happens when you get improper history or inadequate history from the patient. The history is inadequate. If you are not getting an idea of where to localize, then we have to do in cursory examination initially, as Dr. Chandu has already said. You get some idea of what the patient is having. Then again go back and ask the history again, which are relevant for further localization and find out the etiology. This idea of doing focused examination may initially sound challenging, but in reality, the principle is quite straightforward. The basic concept is start of anticipating any neurological condition when the patient walks into your office. For example, an old man walks into the room with a symmetrical tremor of one hand, with a slow gait and stooped posture. The diagnosis is obvious. You may do at best do some examination without any typical Parkinson's. On the other hand, if the patient happens to be an younger age group, then you may not ask 11 questions history to find out the cause of young onset Parkinsonism, like in the Wilson disease, etc., etc. Here, many other aspects in the history examination become relevant. So the examination is now tailored to rule in and rule out other causes of young onset Parkinson's. This is a skill that gets better with experience, as Chandrasekhar has already told. Early in one's training, one is less versed with about the plethora of neurological conditions one may encounter and should do a thorough examination to avoid missing an associated signs that may point to an unexpected diagnosis. But always use your common sense. Just finding a particular sign or a subtle sign has no meaning if it does not go with the patient's complaints or rest of the findings. The experienced clinician will know what signs to look for in a particular presenting complaint and can more easily and often subconsciously exclude significant parts of the examination that may be irrelevant in making the diagnosis. So I will exemplify 2-3 case histories, project 2-3 case histories. That's the point which I made in my talk. Only 2-3 short case histories. This is 65-year-old diabetic patient came with history of paresthesia in the left index finger 1 week back. Along with this, he noticed difficulty in picking up small objects, buttoning the shirt and occasional dropping of the object. No other complaint. The complaints remain as such since then. So history-wise, numbers of the index finger and from difficulty in buttoning the shirt, maybe carpal tunnel syndrome in a diabetic patient. So started examining the patient in that angle. Examination showed he has got the nail sign was positive. He could not oppose the thumb and little finger. It was slipping away, indicating that opponent is weak. I quickly did the other examination. The interosseous lumbricals were normal. Then I started looking for the abductor, any other muscle weakness, the Thénard group. The abductor pollicis brevis was normal on the right side. It was weak on the left side. It was weak on the left side. So he had opponent's weakness, abductor pollicis brevis is weak, and there is no sensory loss even though you complain of paresthesia. Very often carpal tunnel syndrome, may not have sensory loss even though they have paresthesia. So it's carpal tunnel syndrome in this patient. But there is something odd in the history which makes you think that this is not simple carpal tunnel syndrome. I'll tell you what is that odd point later on. So started re-examining the patient. You find that in addition to the abductor pollicis brevis, his adductor pollicis is also weak. His Froment signs was positive. And I started examining a little more detail. Flexor pollicis longus was normal. But extensor pollicis longus was weak on the left side. Okay, so that means on further examination, is found to have weakness of the adductor pollicis, extensor pollicis. Now the diagnosis is obviously not carpal tunnel syndrome. What is the diagnosis now? So all the muscles supplying the thumb is affected. So that means this is not fitting with a root or a nerve pattern. So then what's the other possibility? Now we have to think whether it's a cortical lesion, is a pyramidal lesion responsible for such focal weakness. So started examining further, rapid finger movement test for pyramidal lesion, rapid alternating movement in the fingers. These are a normal side. See, on the left side, it becomes very clumsy. So then I did the investigation of the MRI was showing an infarct. So in this case, I did not do any nerve conduction study, not do any cervical spine, straight away went to the MRI brain because of each step I'm doing one after another to try to localize the lesion. Now, what was the clue in this patient in the history of suspected carpal tunnel syndrome? You should drop things from his hand, which is very, very odd for a patient with carpal tunnel syndrome. And what was the clue in the examination? Rapid distal movements are very clumsy or proportional on weakness. I will go to the next case. It's a 47-year-old male. His complaint started 1 week back at 10 a.m. while he was walking. When he noticed numbness on the right sole, later spread to the dorsum of the foot as well as burning pain in the same areas. You know, sensory complaints are always difficult to analyze. They will tell beyond what they really have. He was all right when he got up in the morning. That complaint remained like that. He's not a diabetic, he has no root pain. This examination shows that his motor for acceleration is normal, both proximal and distal. This is a normal. EHL was normal. Plantar flexors were normal. Eversion was normal bilaterally. Inversion was also normal. And you could walk on plantar and heel, walk on toes. His reflexes were also normal. The sensory examination, he was confusing. Sometimes it says that it's more on the left side, and sometimes it is equal. When I tried to take the pin upward, he said there is a level somewhere around the angle. But so what is more consistent was his sensory loss of the sole. But I'm not sure about the other area, but even though his tail is less on the right side. He says there is a level at the angle, he says. Okay, now what's the diagnosis now? So he's got come with numbness of the sole, not the complaint. So we did an NCS. NCS showed he has got decreased EMAP amplitude from the abductor hallucis in the right tibial nerve. This is normal. F5 is normal. Sensory potentials were normal. Even the complaints and numbness, his supraperoneal and sotal were normal. Now, what do you do now? But he has some finding. It's not functional because got weakness of the NCV and the NCS shows decreased EMAP amplitude from the abductor hallucis. So is there something problem with the distal part of the tibial nerve? I don't know. But his plantar flexion was good. So started re-examining the patient. Examine now the muscle which I concentrated was adductor hallucis. It is weak on the right side. We can easily push off my finger, but it was strong on the left side. That means this I did not do initially because that's not we don't do each and every muscle examination in some patients. So that means his adductor is weak. Now again, did the conduction once again the proximal pickup. That shows the gastrocnemius power was normal on the right side, the potential is normal, and did the test for the medial lateral plantar nerve, which had absent potential from the lateral plantar nerve on the right side. So again, initially, with examination, we are not going to do the even small muscle exercise in each and every patient. Depending upon the findings, again, go back and do the examination to find out whether the site of lesion is. So it's got a Task-Turner syndrome on the right side. I'll end with my last case. I think I got 3 more minutes left. 60-year-old man, diabetic person, has presented with complaint of walking difficulty in the form of inability to propel his left lower limb forward for the last 1 year and heaviness of both lower limbs. He said he cannot push his left lower limb very fast as the right lower limb. He also gave history of numbness of both feet for the last 1 year. He's diabetic. This examination, the cruciferous is normal. EHL was normal. Plantar flexus was normal. Flexor pollicis longus was also normal. He had absent anti-check bilaterally and he has got a distal impairment of joint position sense. And this is the gait he had. This is how he walked. And that was his complaint also. A really funny gait. He's walking as a little more effort on the lower limb while walking forward. Okay. I'll tell you what the gait is later on. So it can be something like spasticity, I'm not sure. Absent anti-checks bilaterally, sensory dulling over both feet. These last 2 complaints could be normal. I mean, cannot maybe normal for the patient because it's diabetic. So you go ahead with sensory conduction, motor conduction and sensory conduction, decrease EMAP amplitude distally, sensory, no potential picked up in the lower limb. So what do you think now? Is it a diabetic peripheral causing his walking difficulty? I know you're all not at all comfort. If you must have seen so many diabetic peripheral neuropathy. They don't walk like this. They don't have at the most imbalance while walking. But they're not comfortable with what the diagnosis of peripheral neuropathy. So started re-examining the patient once again. Now, what did you see now? Stand on heel, he could do that very well, but he cannot stand on his toes. His both plantar flexors were weak. So if you look back to the patient's gait now, you observe that he's not but it's not plantar flexing his foot while walking. Heel is striking first rather than the toes. Heel strike rather than the toe strike when you walks about. That tells you his plantar flexors are weak, and walking the knee flexes in between. So what investigation will you do now? That made you think that should some bilateral S1 radiculopathy, and look an MRI showed lumbar disc prolapse and improved remarkably with surgery. I think I have finished my time. Thank you patiently. Thank you for patiently listening. Thank you, Subhash, and all of this.
Thank you, Dr. Madhusudan. I think that was an extremely informative and thoughtful lecture. In fact, in question answer session, we don't have any questions, but we have a lot of praise for both of you. People have really praised you and thanked you for your very, very nice lectures. In fact, only one question one person has asked is that, because both of you made a point that what you need to do in a busy clinic is a very mindful history and mindful examination. For that, you need a lot of knowledge. What the mind doesn't know, I cannot see. So both of you stress that you need to have your good fund of knowledge, and after that do a focused examination. You need not admit the patient. Many times what we do is that when we don't understand, we say, okay, admit. So that is not necessary. If you do a mindful examination and history taking, you can sort out the problem in OPD. Now, in that context, one of the delegates has asked a question that how do you read and how much should you read in a busy practice? I think for that we have a separate session. You keep on following a lecture that how to stay updated for your OPD practice. So I must, on behalf of all delegates, thank both of you for the Sunday morning lectures. You have received a lot of praise. So I once again thank you and hand over to Rahul Kulkarni for the next part of the program. Rahul.
Thank you, sir. Thank you both the speakers. It was wonderful to hear this. I think now we change the gear and we are going towards a quiz. It's a fun time. So relax, open your Slido and maybe try and answer the questions. So this is a quiz that we are running from Pune as well as Mumbai combined. So Rajesh will be there in Bombay and I'll be sitting in Pune and we'll run it. Let's see. Okay, so it's a quiz time, peeking into the history of neurology. And I will request all of you to open your Slido, enter this number K998, and then you can answer the questions. We'll start with the first question. And first, there are a couple of test questions. Let's start with the test questions. So make sure that you have this app, either on the app or slido.com. This number is K998. Make sure that you have it with you. So let's have a couple of trial questions to know how it runs really. Who is the current US president? Obama, Trump, Clinton, or Bush? So I would request all of you to vote. We have got 15 seconds for voting. Can we vote?
How to vote? How to press the answer live?
Okay.
Right.
So this is how we vote. So let's go to one neurology question from a general knowledge question. Which was the venue of the last World Congress of Neurology? Kyoto, Dubai, Mumbai, Paris, and Oslo. So if you can vote. Great. So Dubai, 82%. We know how it works. Right. So I think we'll go to our neurology question. Let's start the quiz. And over to you, Rajesh.
Thanks, Rahul.
Yeah.
So since you will be running the slides, we'll first show the question and then I will ask you to start it so that the questions start. So this is a very easy one. Which doctor was the inspiration for Sir Arthur Conan Doyle in Sherlock Holmes? Miller Fisher, Charcot, Joseph Well, Babinski. Okay, Charcot. So many people feel it's Charcot. No, the answer is actually Joseph Bell. Can we come to the next slide? So we will take it as a trivia. So many people don't actually know what is the inspiration for Sherlock Holmes by Sir Arthur Conan Doyle. As we all know that he himself was a doctor. And way back in 1860, he worked as a clerk with Joseph Bell, who was actually a Scottish surgeon and lecturer at the Edinburgh University. He actually was a detective by nature. He would observe patients very closely and pick up a random stranger, and he can deduce his occupation and recent activities by merely observing him. He was so good as a detective that he was already involved in Scotland Yard investigations in several criminal investigations. Probably he is the pioneer of forensic science. So it was Joseph Bell. Can we go on to the next one? But there are a lot of controversies. So there was this article which came in Brain 2015, where there was an article which was titled "The Strange Case of Dr. William Gowers and Mr. Sherlock Holmes." William Gowers is considered as a pioneer in the father of neurology for the UK. And he also had astute clinical observations. So there is some similarity between his observational skills and that of Sherlock Holmes. However, probably it was Joseph Bell, which was the inspiration to Arthur Conan Doyle for his character Sherlock Holmes. We come on to the next one. But there are some take-home messages from Sherlock Holmes novels for the neurologists. So we all know Sherlock Holmes was a clean, observant guy, and this is very important for day-to-day neurology practice. So Holmes says, you see, but you do not observe. The distinction is clear. That means you need to have a keen eye for observation and deduce what you see from that. And this was amply showed by Dr. Meshram and Dr. Madhusudan. Sherlock Holmes says impatiently to Watson, data, data, data. I can't make bricks without clay. And obviously this translates to history, history, history. Without a good history, you're nowhere. And that's what Dr. Meshram said. Holmes also said a man should keep his little brain attic stocked with all the furniture that is more likely to use, and the rest he can put away in the lumber room of his library where he can get it if he wants it. So don't stack your brain with unnecessary data. Listen to all the fine morning seminars and probably you'll be stacking them with useful data. And the last one, how often have I told you that when you have eliminated the impossible, whatever remains, however improbable, must be the truth. And this is so true of many of our chronic diseases. We think it's a rare disease, but probably this is very true in our case. We go on to the next one. So which was the first lacunar syndrome which was described by C. Miller Fisher? Pure sensory, ataxic hemiparesis, pure motor hemiplegia, or the dysarthria clumsy hand? No, the answer is pure motor hemiplegia. Yeah. Next one. So a brief on Charles Miller Fisher, a excellent clinical neurologist, a Canadian neurologist. What is interesting to know is at the age of 28 years, he was actually in the Canadian Navy and he was shot down by a German Navy boat and he was captured as a prisoner of war. And it was during this 3 years of prisoner of war, he was interned and which led to his excellent observational skills. He was a good pathologist also. So because of this clinico-pathological correlation, he could establish various disease correlations like the role of carotid disease and stroke, atrial fibrillation and stroke, posterior fossa bleed and brainstem compression. Obviously, these have now translated to therapeutics. Most of the major lacunar stroke syndromes have been named by Charles Miller Fisher. The GBS variant, his observation also led to the phenomena of CSF tap in those with normal pressure hydrocephalus. Though the clinical phenomenology of normal pressure hydrocephalus was described by Hakim and Adams, it was actually his observation which led to the therapeutics of CSF drain. He is also responsible for the Fisher grain of predatory vasospasm, transient global amnesia, and many, many more. So he was an astute clinical neurologist. Let's go on to the next one. Muscles of facial expression were studied by Faradic stimulation and then photographed by which physician for the first time in history? Was it Raymond Adams? Was it Magendie? Was it Daroff? Or was it Duchenne de Boulogne? Wow, I think it's a good guess, but yes, it is Duchenne. Go on to the next one. So we remember Duchenne's by Duchenne muscular dystrophy. However, he has a lot of other things to his credit. He was the first clinician to practice muscle biopsy with his own invention. He invented his own trocar way back in 1830s. He was one of the first physicians to actually advance the field of electrophysiology, and he was probably the first clinical electrophysiologist. He is the first clinician to adopt clinical photography. Next one. So various muscle diseases, the TAPes dorsalis, the progressive bulbar palsy has been described by Dushin, and he was very, very interested in the field of physiognomy. So physiognomy as a branch was basically looking at people's faces and then predicting his personality. Dushin felt this was a way to look into their souls. And hence he was very fascinated by what happens when you stimulate particular muscles, and he would photograph them. So he was the first person to actually photograph his own experiments. And the true smile, where you make you utilize your muscles of the mouth and the eyes, which are called genuine smiles, are actually called Dushin smiles. Let's go on to the next slide. So these are actually photographs by Dushin, where he has stimulated by Faradic stimulation patients at the La Salpêtrière Hospital in Paris. These were actually insane patients, and all of them were photographed to check muscles of facial expression. So Dushin was the first clinical photographist. Over to you now, Rahul.
Thanks, Rajesh. So let's run the next set of questions. Okay, so who used the reflex hammer for the first time? Was it Taylor? Was it Krauss? Was it Babinski? Or was it Stromner? Can we have the answer here? Okay, majority thinks it is Stromner, but the correct answer is Taylor. It was Taylor who in 1988 used the reflex hammer for the first time. The reflex per se was described, muscle strip reflex was described by Erbs and Westphal, and it was Taylor who really used this hammer. You can see this triangular hammer that we still use, the rubber hammer, which comes in the color of black or sometimes in the color of orange. This is a hammer which was described by Taylor in 1888. It was other types of hammers which were described almost 10 years later by Krauss, and then maybe by Stromner. And then we had a hammer which was described by Berliner, and then there was a hammer which is described by Babinski, none other than the Joseph Babinski. And from the Joseph Babinski hammer, it was a queen square hammer, which is being widely used nowadays, has developed, but it was Taylor who really used the first hammer, and the first hammer was called as Taylor's hammer. Okay, we'll have the next question. The next question asks, who was a practicing neurologist who had won a Nobel Prize? Was it Camillo Golgi? Was it Raymond Cajal? Was it Moser? Or was it Prusiner? Can we have voting here? Okay, so 60% think it is Prusiner, and the correct answer is Stanley Prusiner. It was Stanley Prusiner. The other three people also have won Nobel Prize, but remember that they were not practicing clinicians. They were neurologists plus pathologists. The older people like Cajal and Golgi, we know, were pathologists plus neuroscientists, but it was Prusiner who is still a practicing neurologist. We know that he works in San Francisco, in the University of California, San Francisco. Is in fact director of the Institute of Neurodegenerative Disease, and he is the one who described this mad cow disease, and he is the one who coined this term Prions disease, and he actually won the Nobel Prize in 1997. And some of you would know that Stanley Prusiner has visited India, and he has spoken in a few of the meetings in India. So he was a practicing neurologist. So practicing neurologists can win Nobel Prize. Okay, we have the next question. So who do you think is considered as father of the modern neurosciences? Is it Galen? Is it Cajal? Is it Charcot? Or is it Gowers? Can we have voting here? So we are asking of the father of neurosciences. Okay, 61% people think it is Charcot, but the correct answer is Cajal. It was Santiago Ramon Cajal who was considered as father of the modern neurosciences. He was a Spanish neuroscientist and a pathologist who won a Nobel Prize with Camillo Golgi, but he's the one who first described that in the brain there are multiple cells which are called as neurons, and it is the neurons which are connected to each other with the help of dendrites. Earlier it was thought that the whole brain is considered to be full with all reticular, and it was called a reticular theory. It was Cajal who first described this neuron theory, and he is considered as father of the modern neuroscience. He also described the axonal growth cone, how the cells, the axons grow. He also described something about dendrites, though he did not name as dendrites. And of course, we know that he described this interstitial cell of Cajal, which is present in the GI tract. And also, he also described the interstitial nucleus of Cajal, which we know is important part of neuro-ophthalmology. So let's talk of certain other more father figures in neurology. Father of modern neuroanatomy is considered as Thomas Willis. We know that circle of Willis has been described by Thomas Willis. He was the 17th century anatomist who described the brain anatomy for the first time. So he's considered as father of neuroanatomy. The father of modern neurology is Charcot. So Charcot is not the father of neurosciences. He's considered as father of modern neurology. And we know about Charcot a lot. There'll be one more question on Charcot, which will come in later. And then father of American neurology is considered to be Mitchell. He's the one who described causalgia for the first time at the time of American Civil War. And then the father of British neurology we know is William Gowers. So these are certain father figure in neurology. So we go to the next question. So this is an Indian question. Where was the first neuroscience department started in India? Is it Madras, that is Chennai? Is it Bangalore, that is Bengaluru? Is it Vellore or it is Chandigarh? Can we have voting here? Okay, 50% people say it is Chennai, but the correct answer actually is Vellore. The first neuroscience center department was started by Professor Jacob Chandy in Vellore in 1949. And then thereafter, of course, Chennai was there, then there was Banaras, there are other centers, but the first center was started by Jacob Chandy in Vellore in 1949. A similar question, again Indian question. See these four figures and answer this question. Who was called as Papa Neuron or Grandfather Neuron in India? See these four faces and then answer the question. A, B, C, and D. I'll go to the question now. Please answer. These were four father figures in neurology, neurosciences in India in 20th century. Senior people. Okay, so we have a mixed house here because at the department in Vellore. Third is E.P. Bharucha, who was one of the first practicing neurologists in Bombay. And last one is Professor Ramamurthy, who is the neurosurgeon who started the department in Chennai. So Dr. Baldev Singh was a Padma Bhushan awardee. He started NSI in 1951 with others like Jacob Chandy, he was also credited for pioneering the epilepsy surgery in India. He helped to establish the Department of Neurology in AIIMS. Post-retirement, he worked there for 3 years. He was fondly called as Papa Neuron or Grandfather Neuron in Indian neurology circuits. Okay, one more question. We all know about this book, which was published more than 200 years back, Shaking Palsy by James Parkinson. So there's a question coming on the book. So in the book, which was a feature which was not described correctly by James Parkinson? He described all these features 200 years back, but one feature he did not describe correctly: dementia, constipation, fascinating gait, and asymmetry. Can we have voting here? Okay, 43% people say it is dementia. So the correct answer indeed is dementia. So if we go to the books, you see this is what has been described by Dr. James Parkinson. He says that the power of the mind is unimpaired. So he said there was no dementia in these people. He of course described that expulsion of the feces from the rectum sometimes require mechanical aid. So patient did have constipation. He said that the patient had fascination, so propensity to bend the trunk forwards and pass from a walking to running pace like destination. And then he also described that the disease involves one arm and one hand. So asymmetry was described by him. He called the disease as shaking palsy, but it was Charcot who said that the disease must be named after Parkinson, who described this disease. So the name Parkinson disease was coined by Charcot from the disease which was called as shaking palsy earlier. Okay, one more question. So which amongst this is the EN and IN? Can we have voting here? 4 associations in neurology. Okay, 40% people think it is American Academy of Neurology, but the correct answer is ANA. So, in America, there are two associations. The older association is called as American Neurological Association, and the newer one is called as American Academy of Neurology. Of course, then we have European Academy as well as Indian Academy. European Academy actually is the newest organization. There were two organizations called as ENS and EFNS. They were merged together to form this EN. The oldest association is American Neurological Association. It was founded in 1975. American Academy has been formed in 1948, while Indian Academy we know has been formed in 1991. So the oldest association is actually ANA, which also runs a journal of Annals of Neurology. Okay, so you see this picture. We all know which disease it is. And the question comes next, who is the person who described this amongst these four? You see these four faces, and then I'll ask you the question. I think two of them you already seen in the lecture, in the quiz earlier. So I'll ask the question, who amongst these four have described this disease? A, B, C, D. Okay, 43% people say it is B, which is indeed a correct answer. So first person is Duchenne, which Dr. Benny showed us. Third is, of course, Charcot, which we know. So second is von Recklinghausen, and fourth person is none other than Nicholas Friedrichs. So von Recklinghausen was a German pathologist who described this disease called neurofibromatosis type 1. He is the one who also described hemochromatosis. So the next question is, you see this disease, and we all know which this disease is, and this disease has been described by a person. You need to tell me who was a person who described this disease. Was he a physician or a neurologist? Was he a surgeon or a neurosurgeon? Was he a radiologist or was he a pathologist? Can we have voting here? Okay, 43% people say it is pathologist, which indeed is the correct answer. We know that the majority of the diseases which were described in 20th century were described by pathologists because they were radiologists at that time, and the role of neurologist or neurosurgeon was not very high at that time. So this was a disease which was described by a pathologist who was Hans Chiari. He was an Austrian pathologist who also described another disease called as Budd-Chiari syndrome, which is related to gastrointestinal tract. And the person who was with him was Julius Arnold. He was also a pathologist. Both of them were pathologists who described this disease. It is Chiari, whose name is more often associated with this rather than Arnold. Going to the last question, we know that Charcot has been considered by many as a father of modern neurology. He trained many students who later become very famous neurologists. So you have to tell me who was not his student. Tourette, Duchenne, Sigmund Freud, and Babinski. Can we have voting? Okay, 45% think it is Sigmund Freud. The correct answer actually is Duchenne. So Charcot, we know, worked in this famous Salpêtrière hospital, and he actually considered Duchenne as his teacher. So Duchenne was not his student, but Duchenne was his teacher. And he trained a lot of students, which include Sigmund Freud, who later became father of psychiatry, Joseph Babinski, who described the Babinski sign, Pierre-Marie, with whom described this Charcot-Marie tooth syndrome. He also trained Bouchard, who described the Charcot-Bouchard aneurysm. Tourette, was his student. Alfred Binet, who described this test of IQ, Binet test, has been described, was his student. So also was Pitres, who described a sign called Pitres sign in neurosyphilis. So he trained a lot of students, and his legacy still continues in the world of neurology. I think I'll stop here. I hope that you all enjoyed this session. Thank you. Thanks a lot. And we go to the next session now. I'll hand over to Dr. Gursani and Dr. Kothari.
Yeah, I think the next is Dr. Gursani. And as
Yes.
you know, the ICMR has recently given one of the
Rahul,
DNAR things.
you should ask them, did you enjoy the session? Yes, no. Next time.
We'll put a question like this. Okay.
So I think Dr. Gursani is going to tell us about the new happenings in the DNAR on which he has been working for such a long time. So Roop, your stage.
Yeah. Yeah. So can I invite, hello? I think my...
Yeah, we can hear you. We can hear you.
Yeah. Okay. No, my video has still not been started by Okay, that's okay. Can I invite Nagesh Simha in at this moment? He's going to chair this session and he's going to take this all forward. He will introduce our speakers. And Nagesh, are you there?
I'm there, but my video has been blocked.
Yeah, yeah. So Mansi, Sudhir, can you open up the videos?
I got all dressed up, yeah, for this.
Everybody's video is on only.
With my video blocked.
Not mine.
No, you have to probably...
Here. I'm also here.
I'm told that you can't start because the host has stopped it.
Yes.
You can start. So I'll say I'm sending you a notification. You can click on start video in that.
Okay.
Okay. Right. So are we ready to go?
Let's so.
Yeah, yeah, you're seen.
Can you see me? Can anybody see me?
Yeah, yeah, you're also seen.
Okay.
All right. So great privilege to be part of this wonderful webinar. And it's a vexing question that we keep talking about in terms of do we or do we not attempt resuscitation. So we have a very eminent panel, two speakers and a few who will participate in the panel discussion. So I will introduce them very quickly in alphabetical order. One is Anand Bhan, who is a well-known researcher into bioethics, global health and health policy, and an immediate past president of the International Association of Bioethics. And he is an adjunct faculty member of the Yenagoa University and Kasturba Medical College in Manipal. The second person is Dr. Rajni Bhatt, very eminent pulmonologist, but she's become a lazy girl. She's on an extended sabbatical because of COVID, deeply interested in palliative care, and a governing council member of the Indian Association of Bronchology. And in her fairly large spare time, she does a lot of work for the powers that be in Delhi. No more information. Rest of it is secret. The third is Roop Gursani, of course, all of you know, eminent neurologist, gradually forgetting neurology and getting more into palliative care. He won't like me for saying this, but he's been doing some really fantastic work and the convener of the End of Life Care Task Force. Then, of course, we have Dr. R.K. Mani, who is an eminent pulmonologist and critical care physician. He is the medical director and CEO of Batra Hospital, and somebody who's done some very, very good work for over 20 years on the whole aspect of withholding and withdrawal. And finally, we have Dr. Dhwani Mehta. Don't get confused. Luckily, she's not a medical doctor. She is an advocate, a PhD from Oxford, if you please. And she is a member of a think tank called Bidhi Center for Legal Policy, which has been advising governments on law and has been working with us very closely. So with this introduction, I will now request Dr. Rajkumar Mani to speak on the topic of withdrawal of life support, 20 years of experience, not only Indian experience, but international experience. And all the speakers have promised to keep to time. So Raj, you have got 20 minutes and your time starts now. All yours.
Can you see the slides?
No.
You have to share your...
see the slides?
No, you're going to share the screen.
How do I?
So there's a green button at the...
Okay. There we are. Yeah. Now we can see?
No.
Yes. No, you will have to click on that, and after that you will have to select your presentation.
Then your desktop shows up.
Got it.
Yes.
Got it?
Yeah.
There we are.
Yeah,
yes. There you are.
Yes.
You can see it there. All right. Okay, here we go. So this is a topic close to my heart. Of course, for 20 years, this is what we have been doing. We've been mulling over the question, when do we stop? And we are still mulling over that question. And barriers to limiting life support in India, these questions, these barriers still limit us and bedevil us, our progress. So let me move on. Oh, it's not moving though. It's moving. All right. So what is the context really? Context, we always mull over limitation of life support in the context of law. And actual context is disproportionate medical interventions are rife in the ICU. So it all looks very glamorous, all these equipment around around the dwarfed figure of the patient, dwarfed and drowned by the sound around him. So it begs the question now, I mean, all this push towards life-saving technology, what has it done to the human being? Now, Schulz wrote in her book, A Chance to Say Goodbye, that was about her father's dying time, that it should be balanced with options for comfort care so that more and more people would have the chance to transition to death with dignity and grace. So these are the key words, dignity and grace, which have to be integrated into our practice. So fundamentally, in India, what has happened is barriers to foregoing of life support, which seems so natural towards the end of life, it is rooted in a sort of malady, a mixture of ignorance about the subject, prejudice about it, and suspicion of the medical profession in general. First of all, let's ask ourselves the question, the first barrier. Where is the openness about death? I think it's all very hush-hush affair. It's all a taboo subject, death and issues around death, so that we have never explored it. It's so much so that we don't even mention it. If there is a brain death in a patient, you don't even mention it out of context with a transplant situation. Brain death, I've often seen my neurologists write very grave prognosis. When I ask them where is the prognosis after death, but that's the sort of mental block that we have about discussing or even mentioning death. Second, do we discuss the human needs in a technological environment? I mean, where is the human being in all this? We talk about the disease, we talk about the symptoms and signs and all the tests around. We discuss the machines, we discuss the numbers, we discuss the calculations, we discuss the economics and the law, but we don't discuss the compassion that is needed in the care of the dying. So the three of us, myself, Roop and Nagesh, wrote this article in TOI Middle a few years ago. They're raising this very question and then raise the issue that we must talk about death. There is nothing to be achieved by not talking about it. We don't understand it. In fact, we torture the question of death and our patients in the process. That's what Atul Gawande alluded to when he said modern life and modern medicine has complicated the word dying. We have to understand again, because of the complexities of medical science, which can keep alive a person's body meaninglessly, we have to ask ourselves the question, how best to die? So we must see what we go through. We must experience what in every family we go through. That how people die, how the loved one dies, remains in the memories of those who live on, said Dame Cicely Saunders, the founder of hospice movement. And there is an institution by her name in the UK. Third, do we even consider when not to do too much? You know, the background was disproportionate treatment in the ICU. And now, do we recognize, do we ask ourselves, stand away from the bed a little bit and ask ourselves a deep question that, are we doing too much? Should we lay off? Or is it okay? Because disproportionate treatment is indeed harmful in a multifaceted way. It harms the patient by prolonging death, and that is a very hard thing. That's a very uncaring thing to do. And then we are going against bioethical principles. Don't ask me what are bioethical principles. We come to that. In fact, we need to discuss. We need to ask the question, where are the ethics in all this? And then the family is weighed under deep economic distress. We see that every day. And for the caregiver doesn't go scot-free in all this. It causes moral distress. There is plenty of literature on it. And there is so-called compassion fatigue. And there is a lot of leaving work. I mean, not able to continue. And there is a lot of literature on this too, data. Ruth Pius has done a lot of work on this, on compassion fatigue, on the ethical environment and how caregivers are impacted by it. She's from the Department of Geriatrics in Ghent, Belgium. So one European survey, including 85 ICUs across Europe, showed 67% of patients and 80% of nurses finding at least one patient on a single day receiving disproportionate treatment in their practice. And about 28 to 33% of patients in any ICU had possibility of disproportionate treatment. Having done that, do we also seriously address or acknowledge the issue of prognostic uncertainty in critical illness? In fact, there's prognostic and uncertainty all the way across any prognosis in medicine, but in critical situation, it is even more so, and that needs to be explored properly in communicating with the families. How are we doing that? It is seen in several studies that the doctor or the physicians tend to overestimate the gloomy prognosis, and the family tries to underestimate it, and both of them don't come together very well, and they misunderstand each other's prognosis, and it is beset with beliefs and also vested interests. So a physician tends to, in our country particularly, we tend to exaggerate the poor prognosis for many reasons. It is so-called covering the flanks sort of idea that drives us. So are we being honest, transparent, and informative when we talk to families about prognosis, or are we getting better or skilled at it, or we are getting worse? These are questions we have to ask ourselves. And then the fundamental question is, are we honing the skills of communication? Have we become less communicative in these busy days, or in the technology-driven days, economy-driven days? How good are our skills of communication? How to get the communication right? There are mnemonics which describe it, how to get it right, spikes and value based on consensus, based on practices and convention. There is some recent valuable research. I'll give you a glimpse of that. One thing is very clear. It's a soft skill, hard to acquire. Communication is very crucial. You can see the painting at the top is set in the back end of 19th century. It's called The Doctor. And the doctor is visiting a patient who's dying of scarlet fever or something. And now at the bottom, today, the physician isn't looking at the patient or anybody, he's looking at the box. That is the way we have changed. The back is turned towards the patient. The front isn't there. The presence of the physician isn't there for the patient. It's there only for the data. It can change. We can actually communicate with the patient, even about his or her own predicament and future, and how best to respond to the situation. You can see this is an interesting paper recently published, again from the Belgian group. Practices to foster physician presence and connection with patients in the clinical encounter. So this is a mixed methods qualitative study which based its evidence on literature review, and qualitative interviews with physicians and patients, and interviews with professionals other than physicians. You can't imagine there are others also with a communication challenge, like teachers, chaplain, and firemen. So firemen, perhaps in the emergency situation, we need to learn a bit from them. So they shortlisted, after having passed through all these stages of analysis, they passed through a panel and they reduced the recommendation to 5. So the first one is prepare with intention. That is a mindfulness. We had to focus and concentrate on what we are going to say and how we are going to say it. Then listen. Listening is so important, intently and completely. Firstly, agree on what matters most. Patient important things have to be brought out and addressed. Connect with the patient story. So the overall patient as a person, not as a diagnosis, and then explore the emotional cues. In India, are we talking about the same thing at all, or we are talking about different things? This has been a problem in all these 20 years of practicing end-of-life care. You see, there was this question of Article 21, the right to life. Now, this was interpreted by many to say that we don't have a right to die. We only have a right to, it's a one-sided right. So this is very absurd, but this is the way we have been misinterpreting and torturing simple, understanding in life and death. So to set aside these ambiguities and to bring clarity, we brought out this paper, the Elicit Group and ICMR in 2018, definition of terms used in limitation treatment and providing palliative care at the end of life. This is so important to get on the same page, talk about the same thing, converge about the same terminology. This got 25 terms that are used in end-of-life care. Everything is in euthanasia, just one out of these 25. So do we accept that ethics and morality precede and are the basis of law? See, whenever we talk about end of life or death, or for that matter, we don't talk about compassion. We don't talk about ethics. We don't talk about what is the right thing to do. Okay, we talk only about law. But how can law exist without the ethical basis for whatever the law is accepting or rejecting? So this is the problem. We have been on the bioethical front very backward. We have progressed fast in all other fields of medicine, in technology particularly, and in practice we have progressed a great deal. But in ethical framework, in the ethical progress that the world has made, we have been pretty non-participative. So in 1982 was this book, seminal book published by Principles of Biomedical Ethics by Beauchamp and Childress. So this has become a sort of Bible, and a lot of these, its words have become mantra today in our daily practice. But how have we integrated these principles that are universally accepted today in the field of bioethics as we practice in intensive care or elsewhere? All of these ethical obligations are about putting the patient interest first. All of them except the last one, where perhaps the other interests precede, which is justice. So autonomy, would anyone want to be dependent on machines indefinitely? Beneficence, would it not be beneficial if the patient is spared the burdens that won't benefit? And non-maleficent, would it not do the patient and family harm to be put through physical distress, psychological trauma, and cost interminably? Justice is what we would witness today in the COVID environment. Would you not block a precious bed without justification if you're continuing a futile care? Are we aware of bioethical and legal developments in the world? This is another question. There have been very fast development, particularly since the 1970s, in law, in ethics, legislation, and in practice. And the frontiers are being receding very quickly in the last decade or so. And we seem to be frozen in a different era. We're only thinking of the curative aspect of medicine. The present era is more comprehensive. You can see there's a curative aspect, which is one component of the whole, which includes palliative care and going on to the next phase, end of life care, and going on even to post-bereavement care. Our radar and our scope of caregiving is really expanding wonderfully, and we should be participating in these new developments and exploration. So the evolution has been rapid. It's getting easier and easier to employ end-of-life care and to improve on it with enabling legislation in all these countries. You can see so many countries, and they are in the forefront. And this was the back end of, I think, 2017 was this image published in New England Journal. This patient turned up in the emergency. He's a chronic alcoholic. He had had repeated admissions, and he had broadly, tattooed across his chest, "Do not resuscitate." So loud and clear for everybody to hear, and therefore he was not interfered with. So, but
Raj, you've got about 5-6 minutes left, please.
All right. Yeah, I'm going to finish in 5-6 minutes.
Thank you.
So
Thank
the
you.
myths have replaced reality as far as DNR is concerned in India. DNR is not a form of euthanasia. Actually, it's the simplest form of treatment limitation on the opposite end of the spectrum occupied by euthanasia. Suicide and abetting suicide cannot apply to a dying process already started. Misuse of treatment is the word we keep on hearing. Misuse. However, the misuse on the other side of not having an end-of-life policy or end-of-life practice in our midst is really uncontrolled intervention. So withholding really is not to start an intervention at all. Withdrawing is having started an intervention, it is interrupted because there's no ongoing consent to continue it. The challenges that are to be overcome are, in India, there are ambiguities and conflicts of interest which have got all the focus without asking the question, how are the others doing it? In the whole world, it's getting easier. 90% of patients in the ICU go through an end-of-life treatment limitation. And many, many people are entering a hospice rather than a hospital in US and other parts of the world. So you can see withdrawal has been a problem in our country. You can see the two boxed red boxes. They are publications from India. We have very, very narrow band of black as compared to other countries which are broad bands. So you can see there's a lot more withdrawal happening in other countries, and we are pretty squeamish about doing it. So in 2009, this paper was published from my unit. So it was 88 patients and 49 end-of-life decisions were taken through a proper decision-making process. And most of the decisions were made in the first week, more than half. And the first 2 to 3 weeks, almost all were done. You can see that there have been other publications. The withdrawal has been very few in most studies. And in Tata Memorial, there's an informal data personal communication that they are withdrawing in 29%. This paper was published in 2010, impact of an A&D policy, again in the unit I was heading. So you had a before and after study, before an end-of-life policy and after an end-of-life policy. You could see that there was an increase in withholding and withdrawal from 4% to 27% and 38 to 45% after a proper policy and SOP was in place. In France, post legislation in 2005, so the so-called lenity law, they did a survey to see a before and after how things panned out. And they saw that it really didn't make too much difference. 52% of the patients in any case had an end-of-life decision, a treatment limitation decision in the form of withdrawal or withholding. and only 2.6% had advanced directives, and 23% the wishes were known but not in the West. So most decisions were based on medical judgment, which we are so shy of doing. So before the law existed, the practice existed. And after the law, it did not change too much. That's all. So you can see the legalizing voluntary euthanasia is the next step into the horizon that people have taken. And so many places in the US are now buying into it, apart from many other countries outside of the US. So what are we following professional standards and consensus statements is next question. Okay, law isn't there. What about the consensus statements? So all over the world, you got professional bodies, societies giving statements and professional statements. However, our prejudices and narratives hold sway. We don't look that way at all. We do have to ask ourselves, okay, doctors are corrupt, but there are some who may be uncorrupted and incorruptible. And what are they saying? Let's listen to them. So you had this professional consensus statement of the Indian Society of Critical Care Medicine in 2005, which was revised in 2012, and we integrated with Indian Association of Palliative Care to produce this wonderful paper in 2014. And this spells out everything. It's a 20-page document. It's a good resource if you access it on the net. So it's a shared decision-making model that it is espousing, which is, we come together, autonomy and beneficence right together, benefits, non-beneficence, and come somewhere in between in this gray scale. And then we combined the illicit combined with the FICCI to create another document for the end-of-life decision-making, because the private world in India, medical world, is often confused as to what sort of guidance they must give their doctors. So this document is also available on the net, improving end-of-life care decision-making. So this is an algorithm that is given, which is integrated the the Advanced Medical Directive. So if one is competent, then it is our responsibility to sensitively discuss openly the issues about terminal illness, prognosis, appropriateness or inappropriateness of any intervention which we contemplate. And if not, an AMD is available, then with the proxy. And if AMD is not available, then identify appropriate surrogate within the family and arrive at a shared decision-making model through this process, and then implement the withdrawal withholding as a matter of refusal of consent. So we don't have to go through a very difficult legal process. The same similar ideas have generated a document for Kasturba Hospital, Manipal. It's a beautiful document. It's a big tome, including a lot of forms and addressing every doubt one may have. So then we went on to do the DNAR document along with ICMR, illicit and ICMR. So you have this recent paper out there in the public domain. CPR is not always good. I would say CPR is mostly not good in certain circumstances. And this is the whole point of DNAR. So in COVID times, what do we do? Let's see what we can do, integrate in the present times. Do not attempt resuscitation, not only patient-centric, but also serve public health and caregiver interests. This, you must understand, is a huge risk of CPR as a very big aerosol generating procedure, which can spread the virus across all health caregivers and in the hospital and other patients. So family communication must include discussion of treatment withdrawal withholding, especially when the deterioration is refractory and in poor prognostic scenario in the elderly, and meaningful outcomes of CPR in refractory critical illness is less than 5%, which should be conveyed to the family. So protected CPR is the new term. Anticipate crises early and move the patient to critical areas. So if you must do CPR, it should be under full PPE, which may in fact include the highest level of protection, which is called powered air purifying respirator, or PAPR. Resuscitation trolley should be in the anteroom, and assistants may hand over drugs, defibrillator, paddles, etc. to the resuscitation team inside. So goals of care setting becomes even more important because mortality above the age of 80 or 75 is 15 to 22% in China, in Italy, and in Europe.
Raj, 1 minute more.
Yes, finishing.
You've gone way above time.
So this is a treatment
Sorry.
limitation, very important. So this is one of the cases where we gave a dignified death to a religious personage. Do we inform rather than passively receive national policy on end-of-life care? This is the last searching question we have to ask ourselves. Because if we have a tortuous route of legal reform, then it doesn't mean at all that we are exercising our rights, because exercising it becomes so impossible. So points to ponder are we caring for patients with poor prognosis differently? If we do so, then ACP and WDWH are inevitable. Are we integrating palliative care in our practice enough? If so, then both of these are inevitable. Have we over-legalized treatment limitation and missed the point of caring? And how on earth are we professing evidence-based medicine? Are we doing enough to get the right legislation? Then how are we going to practice with morality and integrity and protect the image and the trust in the profession? With that, I finished. Nagesh, I hope in time. Okay, Nagesh, done.
Thank you, Raj. And whoever is controlling this meeting, please open my video. I'd like people to see my wonderful, handsome face as I'm chairing the session. We will now request my good friend Roop Gursani to speak on the ICMR DNAR guidelines and what next. Roop, please go ahead.
Yeah, so I'm waiting for my video to be put on, and yeah, and I'm getting my yeah, I'm asking for starting my video. Yes, here I am. Share screen. Yes. Just a sec. Just a sec. Yeah. Here we are. Right. Thank you, Nagesh. And thanks everybody else for coming up on a Sunday morning. Since I'm one of the organizers, I'm not sure I can thank myself, but I do have to thank Sudhir for pushing me to do this. And it's good to get the information that we already have out into the public domain. So most of you are aware that in India, it's not very difficult to take control of the last days. And this was a question that Sudhir was supposed to put out on Slido. Sudhir, have you done that, or are we doing anything about it? Is Sudhir there? No. So most of you are aware that there was a recent ICMR article on DNAR. And the question was to ask you what it was. Actually, it's a policy document put out as consensus by an expert group to form what are termed consensus guidelines. And to tell you about cardiopulmonary resuscitation, this began in 1960. And today we recognize two forms of it. One is that occurs after primary cardiac arrest. And the recommendation here is to focus, especially when it is done by bystanders, on chest compression only. And the aim is to focus on preserving cerebral supply, blood supply. And in those individuals who get secondary cardiac arrest after hypoxia or hypotension, then the classic CPR, where you start with airway, breathing, and circulation, applies. The first is typically out of hospital arrest, and survival to hospital discharge rates, even in the best of circumstances, are still well under 10%. In some situations, as low as 1 or 2%. Whereas in hospital arrest, as you can imagine, survival up to 40% is possible. So let me begin by telling you of 3 stories that I am personally aware of. The first is this young man who was playing Maidan cricket. He was in his 40s, obviously not terribly fit, because in the midst of the game, he suddenly developed chest pain and collapsed. And as it turned out, fortunately, the teams next to him on the Maidan were actually were doctors. So they rushed across, they started chest compression, and fortunately, his heart restarted immediately. He could be taken to a nearby hospital, and he received stenting, and he did fairly well. The next is the story, actually not mine, but contributed to by a friend who, when he was in the UK as a registrar, had this elderly gentleman with a cardiac issue admitted in the ICU who had suddenly one evening recurrent bouts of cardiac arrest. And obviously the resident and the team rushed up. The usual shout of shocking went out. The old man's body jerked and his rhythm returned. And this happened 3 or 4 times before things settled down, before the cardiologist came in, changed the drugs and so on. And when it was over, the old man was actually conscious. And then he called the resident, who happened to be my friend. And when my friend went across, the old man looked into his eyes and told him, "Young man, you will not do that again to me. Let me go in peace." And this information was conveyed to the treating team. Palliative care was called in. This was in the UK. And the patient was moved out of the ICU and apparently passed away a few days later at home. The last was my own patient with dementia in the hospital with a bad pneumonia. I was talking to the family about a DNAR decision, and the family was not particularly keen on doing that. And as it turned out, she crashed, and it literally happened when I was coming into the round. And as they started, I could hear a crunch, and one of the residents said, "Oh shit, her ribs have cracked." Well, they did manage to get her into the ICU, and finally the family also agreed, and sometime later that day, when she arrested again, she passed away. So the ethics of cardiopulmonary rescue are basically 2 competing ethical models. On the one side, you can look on it as a procedure like any other. So it's then governed by the rule of, autonomy and informed consent. Or you look on it as something that is governed by the rule of rescue, which is based on the principle of beneficence. And in this paper, the authors argue that CPR must be provided by default unless the patient has clearly refused it in advance or if it is likely to be futile. And discussions are necessary to elucidate the patient's values, in which the patient does have a negative right to be protected from CPR, but not an absolute right to demand CPR. So, if you remember, CPR started in 1960, and the DNAR order started somewhere in the early 70s, not very long after that. And again, from this editorial too, it seems that to presume that somebody wants CPR is not always correct, and you actually have to check. Now, these are conversations that are not easy, but you can learn how to do them. And this is from the British Medical Association. Anybody who's interested, this has a very detailed discussion. And in that, it makes a mention that these are not easy discussions, but you do need to learn how to have them. I, Dr. Rajmani, and to some extent the whole ELICIT team, we were involved with producing this document, which came out from the Indian Council of Medical Research earlier this week. And it's important for you to understand that the premier medical think tank of the Indian government is telling you that this is good medical practice. And this has the DNAR form that we have argued about so long and so much. It finally is there for you to use. This gives an algorithm, and the algorithm says, does CPR have a realistic chance of success? If it is no or not sure, then either the patient or the surrogate needs to be informed about this. Now, this needs to be discussed sensitively in simple language. The patient's values need to be elicited. The patient's choice has to be respected. And these decisions are taken in the best interest of the patient overall. But the final decision is with the physician, and CPR is not to be performed on demand. Whatever it is, you document it completely and you continue supportive care even with DNAR orders. The question that is always asked, does CPR have a realistic chance of success? The thing is that the information is with us. We are the doctors, and the problem is that when patients expect us to prognosticate honestly, accurately, and optimistically, we find it difficult to do. But it is a personal responsibility. Because we are not trained in the skill of delivering bad news, we accept this rubbish that is called usko mat batao. So the community also needs to understand honesty is really the best policy. Very often when these decisions are not communicated, we end up with a problem. But it's not just an individual doctor's responsibility. It also needs a system. And the system, Dr. Mani told you about the system for making these decisions. There's a due process for foregoing life-sustaining treatment. Basically, we need a consensus amongst the treating team. Typically, for instance, in Hinduja, we would have to have 3 consultants agree on this. Then the surrogate decision makers also need to be on the same page and a consensus amongst them. The whole process, the whole clinical note needs to be documented, and ideally there should be a post facto audit. And these are the various documents that are already in the public space. The AIIMS of Delhi is producing this document for itself together with the DNAR. All of these are out. Now, all of these are based on the basic principles of biomedical ethics, autonomy, beneficence, non-maleficence, and justice. And remember that this is a book that has been out now for, well, it's the 7th edition. The first one was 1979. There has been a fair amount of discussion about how to apply these basic principles to the clinical situations. And if anybody is interested, I'm not going to spend too much time on this. This is called the 4-box model, where you combine these various basic ethics into medical indications, patient preferences, quality of life outcomes, and contextual features. And you can look at all the questions that are there and see how they apply to your individual patients. But you will ask me, how can you compel me to do this? Do we have a law? If we don't have a law, how do I know this is not illegal? But I am an optimist, and for me, the glass is half full. You can figure out which one of these other types you are. And let me assure you that these issues are already becoming obvious. Consumer court, civil liability will follow standard practice, especially published guidelines. And in the West, maximum end-of-life care litigation is about wrongful CPR. The first and the only case that we know about is of a Delhi hospital that was fined 5 lakhs for keeping a brain dead patient alive, on the ventilator. So the next question that follows, which I didn't address earlier, which I'll quickly run through, is what if CPR has a realistic chance of success? Should it always be done? Well, you remember that picture that Dr. Mani showed you? It's not just that one picture. There are lots of people who seem to use these tattoos. And I think the confusion lies amongst us. Look at the first tweet from there. Given that the tattoo doesn't have a date on it, how can I trust it? So the sarcastic last answer is, the authors report feeling conflicted about the patient's intent. Perhaps a better tattoo would be the DNR plus a QR code linking to, well, maybe their lawyer. And that is really true. This dilemma is our own. In 2018, the Supreme Court weighed in on what it means to have an advanced medical directive or living will, and they have validated it, although the process that they have put in is a little difficult. But they have said that all adults with capacity have the right to refuse consent even for a process that may save their life. And if there is that on record, you are not permitted to use that procedure. So what you need to prevent that from happening is a living will. This is the draft that Elicit has prepared, and I will tell you the sites which is available. I'm just running through these slides which I have used for public lectures, and just to point out that this document is available on these websites. Vidhi, Pallium India, the Indian Association of Palliative Care, and this can be downloaded. We will be discussing this a little later. 3 people died in 2018, 3 famous people. Barbara Bush in April, Atal Bihari in August, and George Bush in November 2018. Both Barbara and George Bush died in their own bed, surrounded by their own family. Literally in Darbar, they died in state. How did they manage their last days so smoothly? Because they took charge and the system worked for them. Atal Bihari was in an ICU till the end. Now, the living will is just a document. You need a process and a system to make it effective. That system is called advanced care planning. And it's a process to guide decision making about your healthcare if and when you do not have the capacity to decide. It has two components, a proxy decision maker and the guidance for the proxy decision maker. And this is what the US system eventually ends up with, these luridly colored forms that go everywhere in the medical records, in the electronic system, and they're brightly colored because they're also meant to be stuck on the fridge door. If somebody is found down, that's what the emergency medical team first sees. Let me point out that we may not have that brightly colored form, but the DNR form that the ICMR has put out is equal to that. It's always surprised me how we readily import the latest technology. Mechanical thrombectomy came out barely 5 years ago, and all of us have been arguing and deciding how to try it, how to apply it. On the man group, one person puts out his difficulty, and before you know it, 10 people have responded. But this system has been around for 40 years, and we haven't been able to make it work. So this is what I have been telling in the public meetings, that a valid living will needs basically conversations. It needs everybody to speak to those close, to choose surrogates, and then to make this document, which has to be signed in front of two witnesses. Now, the Supreme Court insists that it has to be attested by a judicial magistrate first class, which I suggest, well, you should try it. And if you have any access to them, please go ahead and do it. Worldwide, only 2 witnesses are required. And if at all attestation is required, it's a notary public. Make multiple copies, inform everybody who needs to know, including the surrogates and the family doc. But this is what I have been telling the public. Show it to every doctor you consult, because then they will find out whether the doctor is willing to accept it. The doctors then will be forced to find out whether the hospital's policy is on this. And obviously the doctor will know your wishes. So don't be surprised if somebody comes to you with this document. I've been involved in this since 2011. And along the way, I got some training in the American Academy of Neurology on this. But the basic thing was a realization. One was that as a physician, I could not help my patients to the last. So that is how I got involved in palliative care. I no longer need to say, "Ab main kuch nahi kar sakta," because I can tell them, "Haan, main aapke saath rahunga." But more importantly was a realization, which really drove me in the beginning. And that was that as a citizen, I had no control over my own last days. And we formed the Elicit group here. What Elicit will do next, now that we've at least come so far, one is public engagement to make these living wills and advanced medical directives widely known, written, and used. We have to make doctors familiar. We have to work with the legal system. And finally, we have to make governments and politicians aware that their voters want this. We also want to work ahead to something called donation after cardiac death. And we already have the basic building blocks in place. One method is to see that all major hospitals are aware of withdrawal procedures, foregoing life support procedures. But I'm closing with this statement. Remember that for me, what drives me is the fact that I want my last days to be under my control as much as possible. If you work on this, if you accept this, if you see that it applies to your patients, you will be able to use it for yourself also. So you need to be the change that you wish to see. Thank you. This was another question that was going to be asked. Let's see if Sudhir at least gets a vote on this one. Thank you. Right, I'm done.
Thank you, Roop, for an excellent presentation. So we will now move to the panel discussion. Is that all right, Roop?
Yeah.
Okay.
Is Sudhir there? Did he put it on?
I'm there.
What do you want? The second slide, will you just ask people? I'd like to just, while the panel is being set up.
Okay, so let me share my screen. Go to, people have to go to Slido again. 1 minute. So I'm just 1 minute. So let me share my screen. Okay, so now you join this is a different one than the earlier quiz. So you go to slido.com and enter B384.
B384.
Okay, so the question for you is about the DNAR.
No,
Is
drop
it a
that first
consent?
question.
Is
Take
it a
the next
consensus document? Is it a
No, no.
policy paper?
Drop that. Go to the next one.
Okay, okay. So the second question, how many of you want to download the living will and make it? So will it be tomorrow, before the lockdown ends, sometime this year after you speak to your spouse? You want to think about it still or never?
I think that's me.
Oh, wow.
So one
No,
person.
Only that's me.
We want. It's only 1%, therefore 100%. Okay. Yes, 3. We give them 5 minutes. 2 minutes, at least a minute. Tomorrow never comes, no?
That's okay. Today's Sunday.
Okay, you want to go ahead?
Yeah, I think we might do that.
Okay. So yes, so I can see Anant over there. Anant, can you unmute your? Okay, right. So I will be asking questions to the 3 panelists, Anant Ban, to Rajni Bhatt, and to Dhwani Mehta. So Anant, I'll start with you. Okay.
Sure.
You know, there's been a lot of discussion going on in the context of the current COVID situation. And so I'm going to put to you basically both the questions I will ask at the same time. Is that suppose you had to make a choice about putting a patient on a ventilator, right?
Yeah.
Let's say, for example, there's a 80-year-old lady with respiratory failure. Do you think that it is ethical to advise, you know, to her against putting her on the ventilator? That's part one. And the next thing would be that if you had to choose between a 25-year-old and a 60-year-old person with only one ventilator available, how would you go about it? So I would like you to dwell on these two.
Sure. So, thank you so much, Nagesh. I think these are interesting, clinical scenarios, which also probably throw out a lot of concerns, which are partly moral or ethical in nature. It's certainly the case that in the COVID pandemic, there is a concern about shortage of ventilators, and we have seen that pan out in many countries, and people have talked about, taking decision making around potentially restricting, ventilators only for someone at a certain age cutoff, etc. But clearly, that is a different paradigm. When we don't have that scenario yet in India, we need to have some due process in taking these decisions. So yes, prognosis outcomes, I think, are an important part of that, and that is true, I think, even of COVID-19. As I think Roop said, probably frameworks would be what would be useful. So one useful framework which he talked about was the 4-box framework, which you can apply, which if you go again into more detail, would first thing actually is a clinical criteria, which is there a medical indication? for that person to be on the ventilator? What is that problem that they have? You know, is it acute or chronic in nature? Is it something which can be resolved with ventilatory therapy? What are the goals of treatment that you have? You know, what are the potential risks of putting that person on a ventilator? Will that really be helpful or not? And then the second part being, what are the preferences of the patient? And is that something that you have already some idea about? Are they in a state to tell you? Is that something which has been pre-recorded? Do they have some kind of a documentation for that? If not, then is there a surrogate who can feed that information in, and can that be useful for you? The third one, I think, is a quality of life question, and I think that becomes more important also as you know, as age progresses. Some people might just not want intensive treatment, and Roop gave a couple of examples of that from real life in his presentation. So, you know, what does that really mean to the person? Do they really want that kind of intensive therapy? Would they rather prefer to be at home, especially if they are in having a health condition which pretty much looks terminal? And then, you know, what are the values that would be operative for quality of life? Or, you know, how could you help them make that decision, or their families? And finally, I think what also a lot of people worry about are contextual factors, which is more around justice and fairness. You know, are we being discriminated against someone who has an inability to pay? Are there conflicts of interest? Does the family have an interest in that person not being put on a ventilator? Or potentially, you know, this question of someone wants them to die quick enough because you want to get their property. You know, is there a concern around that? Are there public health interests, as we discussed? You know, in COVID-19, we know that there are sometimes there is an overriding of individual decision-making or clinical interest, which is taken for public health reasons. So I think what is useful, in my opinion, is for institutions to have some kind of a policy and a framework which pre-exists, because then that can be used, and also have a due process where you have an opportunity to speak to the patients, their family members, and then come to a decision which you know, factors in all of these various important boxes of decision making, and then come to, you know, and then communicate it accordingly. But rather than not having that kind of a framework available, which would make it even more morally problematic. So I'll stop there, but I'm sure we'll discuss this more.
Yeah, so thank you for that, Anand. I think obviously it's not easy. And some of the issues that you talked about in terms of framework, etc., is something that our medical community needs to understand. And more importantly, how is it perceived by the public? Because of the great disparity that we have in terms of you know, income and accessibility to healthcare, so on and so forth. So ultimately, it kind of boils down to communicating all these things and making it clearer. So I will now move on to Rajni. But Rajni, you're a chest physician, and first of all, I'd like to know how your patients, like for example, a person with ILD, how much of information do they really want about how the disease will progress? What has been your experience in terms of the need for information or the desire for information?
If I may just request the host to allow me to activate my video. Thank you all for, thank you so much. Yeah, so, you know, really interesting question. I'd actually like to address one part of what the question that you posed to Dr. Anandhan as well, because this has come up once before. And during the influenza pandemic, we realized that there were problems with the ethical considerations and allocation of ventilators. So while in India, we don't have a framework, New York State, CDC, multiple other professional associations have given it some thought earlier. Granted, these are from 2007, 2012, and maybe it needs more updating, considering that there has been an evolution of ethical understanding and acceptance of more, collaborative shared decision-making models. So maybe that's something we can pursue, for maybe the Indian Society of Critical Care Medicine with the ICMR can pursue that going forward. Regarding your question about my ILD patients and how much information they like, it's usually a work in progress, because it's not like you unload on a patient right away in their very first visit about what a life-changing, momentous announcement this is for them when they're diagnosed with ILD. So you have to build a relationship with the patient when they come in, when you're suspecting it, when you're going in for the testing for it, the biopsies, and the final decision. Through this process, you're having multiple stages of conversation, helping them understand the information a little bit more. I usually give my patients educational material, and I don't say, do you want to know more or do you have questions? Because that's the kind of thing that just throws them off, and then they close down at that point. I usually give them the information, having simplified it, and I leave it open. Say, I'm sure you're going to have questions, so why don't we discuss it the next time? And then I seek permission the next time, because it might have been a little bit of information overload. It's very overwhelming. They're all usually putting up a very brave front in front of the doctor. You've got to give them the space to be vulnerable and ask the questions and address their fears and worries. So I will ask permission. Some patients will say on the next visit, some patients will have read, some will have Googled. I encourage it after having read the educational material I have given. I know that most people don't like it, but the Googling of medical symptoms and diagnosis, because it creates fear too. As long as you give them the background information first yourself, then encourage them to seek more information and come back with questions and say, what questions do you have? What are your fears and concerns? What are you worried about for your lifestyle? So if I ask those kind of questions, that's when the conversation moves ahead. Sometimes they're not, it takes a few visits before they're ready to address it. Sometimes they will say, I don't want to talk about it, talk to my wife. In which case I will take up the conversation. Someone invariably within the first 3 or 4 visits is going to come back to you and say, so doctor, tell me really, this is a very serious problem, no? You have to give them the time to be able to come back to you with that. So tell me really, because initially it's like, there's nothing serious, no? This is no, I'll be okay, no? That it takes a little time to shift through that, what is really going on. So we'll all go through our Kubler-Ross phases and we have to support them through that. Most people want to know.
Thank you, Rajni. That's, I think, an excellent answer. There's always this dilemma that we face when we have to communicate bad news, is that, you know, if a patient sort of feels that they really don't want, or they keep saying that they really don't want, how much of it do we really force down their throat? In fact, the need for information, there was a very nice study that was done by our friend Naveen Salins.
Naveen Salins, yes.
And, you know, they said that a large majority of patients do want information. The only question is how much. The other issue that I'd also like to do is this whole question of collusion, right? Mm-hmm. Every time, you know, you want to convey something, could it be an ILD or, you know, for the neurologist, a glioma, whatever. You feel that you need to communicate that, and you know, for example, very soon that the patient will lose the ability to comprehend what you're trying to say, and they keep telling you not to tell the patient. That's the issue of collusion. How would you handle a situation like this in your practice in pulmonology, perhaps?
Okay. This question does come up most commonly in the setting of malignancy, Dr. Nagesh. This question of family members saying, don't tell it's cancer, say it's an infection. You know, and there's collusion on both sides, actually. The family is trying to hide it from the patient. The patient usually has already figured it out, and they're trying to hide from the family that I have figured it out. I have had instances of collusion on the opposite side as well. I've had a patient who did not want his family to know and had made arrangements to get surgery and chemo done in another city, and his family did not know until the recurrence happened. What ends up happening is that I will have a meeting with the family if they're asking me to withhold information, and say that, try and explain to them why it is in the patient's best interests. You know, Naveen Salins' study and Dr. Babde, the Tata Memorial and Manipal people's study, it's been a gift to us in many ways. Because for a long time, people have said this in the Indian context, people don't want to know. That is not our culture. Now we have the evidence to say that 9 out of 10 people want to know. We also have the evidence to say that if you interview patients and if you interview caregivers, 80% to 90% of patients say they want to know. Caregivers, 34% of caregivers say that, oh, they will get depressed, don't tell them. So there's clearly a mismatch between patients and caregivers. Now that we have the evidence of the study, we can use that to convince the family members that it is in everyone's best interest. One simple rule that I follow, Dr. Nagesh, is that I will tell them I will wait maybe 1 or 2 visits. But I will also say I will not lie if I'm asked a direct question. that I will tell them that I'm not going to break the news as this is cancer until all of you are ready to talk about this right away, unless there's a pressing decision right now. I may be able to hold it off for a week or so. But if the patient asks me straight off the bat, doctor, do I have cancer? I am not going to lie. I will support. I will hold their hand. I will be with you and the entire family through the entire process.
Thank
So
you. Yeah,
you have
thank
to
you for
build that team together.
Excellent. Now I move on to Anant. The same question, Anant. If you can look at it from the ethical perspective, I mean, the question that I basically had sent to you was about telling a person with, say, MND about the prognosis, or, you know, is it ethical to push the relatives to say that, you know, we must have an honest discussion? So the same thing that I told Rajni, how would you look at it from, give it an ethical sort of flavor, if I might say so?
Sure. So I think for a clinician or a healthcare provider, your primary responsibility has to be your patient and the patient's best interest. And in that sense, I think you have a responsibility to be honest with them and transparent with them. And it's also their right to know that information. But that does not mean that it needs to be communicated in a direct, heartless manner. It's not just, you know, on your face telling you that you're going to die and, you know, you have 3 years for that. There is a due process which you can adopt. You know, obviously you need empathy. Obviously you need to make them understand the implications of that. A lot of people would like to know because then they can take decisions on their own. Financial planning, you know, speaking to their own family members, etc. So the process which Rajni decided is working with the family.
Roop, can you mute your mic, please?
Yeah, I think he's already done. So working with families as well. I mean, it's also the case that in India, we argue that we are more communitarian, you know, so all this autonomy business is very Western in nature. It's also something which is often thrown back at many of us who talk about that in ethics workshops. But you know, there is no one India, right? I think all of us want to have that mix of wanting obviously our loved ones to be involved in a lot of decision making, but we all would also like our own decision making to be something that we have a right towards or a right on. So I think from an ethics perspective, I just like to reinforce that yes, you have a primary responsibility towards your patient, and that means that I think the patient should know. But how you make sure that that process happens and how that information is passed on to them can be obviously done in a sensitive manner and can involve family members or loved ones of the patient. But at the end of the day, I think now we have enough evidence that, you know, people will often know, you know, by the virtue of having visited an oncology specialist or a, you know, an intensive care specialist, etc., that there is something seriously wrong, and it is their right to know, because, you know, no one would want to suddenly realize at the end of life that, you know, this is something which 3 years ago was something which there was foresight about, and they were just kept in the dark about it. I don't think any of us would want it for ourselves.
Yes.
If I may just raise one point over here, just as a footnote, Dr. Nagesh. You know, one more thing that I have noticed very often, and whether this is to do with pulmonary or with, you know, medical critical care, chronic diseases issues, is that typically women lack agency in this particular sphere. You will find men being granted the opportunity to learn more about their diseases and plan, whereas older women patients will be denied that agency. It's sometimes taken by their children or even by their grandchildren. So as practitioners, we need to be aware of the biases that women patients are facing already. Very often the financial decisions about whether treatment or diagnostics is pursued is in the hands of the person who holds the money in the family. And now you're even taking that last bit of agency and autonomy away if the family is saying, don't tell her about her diagnosis. So let's be conscious about these social biases, because that's also a factor which came up in Naveen's study, that women also said, we want to know.
Indeed.
This has been an assumption that the Indian woman is frail and will, you know, get depressed if she finds out that she's got cancer. No, Indian women are very resilient.
You're a classic example of an advocate for women. Okay, excellent. So basically, from my over 20 years of working in communication skills, one of the things that happens is that when relatives tell the doctor not to tell the patient, part of it is because of the fact that you know, they do love that person so much that they're worried about it. So it's how you handle the situation, how you know, you must be trained therefore in breaking collusion. Now let's move on to the advocate, the lawyer with us, because you know, all of us are worried, okay, that the law will catch up. Corporate hospital, non-medical heads particularly will keep, yelling at us and say, no, 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 it's against the law. So I'd like to ask Dhwani, where do we stand right now in terms of the current end-of-life jurisprudence? Is there enough legal protection, or should we be continue to be worried? Dhwani?
Yeah, Dr. Nagesh. Could I also request the moderator to switch on my video, please? So as far as where we are in terms of end-of-life care jurisprudence, Dr. Roop has already alluded to the Supreme Court judgment of March 2018, which very importantly recognizes that the right to autonomy, which is translated in the context of our discussion today into the right to refuse medical treatment and the right to die with dignity, are part of the fundamental right to life protected by Article 21 of the Indian Constitution. Now, I'm going to address what this means in the context of the DNAR guideline that the ICMR has issued. It's definitely, and I want to reassure everyone who's listening in today that that following this DNAR guideline would in a sense be conforming to a respected body of expert medical opinion, and any adherence to this kind of good medical practice is always in accordance with the law. So there should be no fear that implementing DNAR orders or having DNAR discussions with your patients are illegal in any sense or in violation of our criminal statutes. In fact, not implementing them or not having these discussions is in a sense violating your patient's right to choose whether or not to accept a particular kind of extremely onerous, a treatment that can be incredibly uncomfortable and might not be desirable. So in crux, while the guideline is still a guideline and is not a binding legislative enactment, it's essentially just giving effect to your fundamental rights, and any action that's taken in accordance with it in order to have this discussion and to give patients these rights can never be illegal.
So if I take that forward, Dhwani, suppose somebody says that these are guidelines, I'm very sticky about it.
Yeah.
And I decide not to follow it.
Yeah.
Could, for example, theoretically, one of the family members of that patient take this doctor to court saying that, we have got guidelines? How does it work?
So I suppose the action in this case, if a family member were to take a doctor to court for carrying out resuscitation against the patient's wishes or not giving the patient that choice at all, that would be an action in a civil court, in a consumer court for based on the legal ground of the action would be having violated the autonomy of the patient because the patient wasn't given the option to choose to refuse medical treatment. So again, the consequences of that would probably be, the only sort of remedy we have for this are damages. So that would be the practical consequence. But the court, while deciding whether the doctor had acted appropriately or not, would take into account whether as I mentioned earlier, whether the doctor had acted in accordance with a responsible body of medical opinion. And if it's, and again, this is up to the medical community to decide what is the kind of weight and value that it wishes to give these DNAR guidelines. Of course, as Dr. Roop mentioned, they reflect the consensus position of the leading medical institution of the country. So there's obviously a great weight that attaches to them. And I would imagine that any court, while judging whether a doctor had acted properly or not, would view negatively failure to implement or comply with these guidelines. And I suppose there would be, accordingly, in the same way, there would be professional disciplinary action against doctors who didn't do that as well.
So looking at it in a more positive sense, following the DNR guidelines is safe and good practice.
Absolutely.
You need not be worried.
That's right.
So that's the bottom line. Thank you, Dhwani, for that wonderful answer. So I go back to Anant right now. This whole business of discharge against medical advice and, the person can't afford or this or that, right? So what are your thoughts about that?
So I think one of the things is, it's a process of any discharge is a process. And I think a lot of these conditions and situations can be anticipated. It's probably important to work with patients or their surrogates in advance of such situations. I think what is most troubling probably is when this is a sudden phenomenon. You suddenly decide and say that, well, your money is run out or you've not paid your bill. So I think the way to solve this is let's let you go. You can go against medical advice, or you can leave against medical advice. We all of us will know that not everyone does have the insurance or the finances, and the cost of intensive care can be devastating for families. And we also know that healthcare is among the leading causes of indebtedness in our country, and especially now with post COVID-19, with people losing jobs, etc., it's going to be even more acute. This is not just for COVID-19, but non-COVID-19 care as well, that we need to be cognizant about financial implications of healthcare, especially high-cost healthcare. So I think it's important to make families understand multiple things. One is, that there are costs involved, there is a futility question, that, some care, yes, you can keep, but this with them towards that and say, there are these are the options that we have. Yes, we can keep this person on intensive care, but this is probably futile and it's going to cost. Or the other options might be transition, step down care, palliative care, care at home, etc., and then with supportive mechanisms for that. If we do that, I think we are building the case that the family feels supported through that transition process. And I think it's in the family's interest, it's in the patient's interest to then make those decisions once they have that information and the support available. But if it is very abrupt and not a transition or a process, then I think you will open yourself up for the kind of situations where we see violence happening in institutions. Deaths happening, people making accusations that this is exploitative care. They just kept on piling on the bills. They never told us that this would happen, X would happen, Y would happen. So why not try to approach it from a conversation process, from a due situational process, and then say, okay, we can anticipate some of this, and let's try talking to individuals in advance of that, or families in advance of that, and maybe that would be much more helpful. That transparency.
Thank you, Anand. That's a wonderful answer. Actually, one of the fears that many of the administration, particularly the non-medical guys, have is that they insist on a Dharma or Lama, whatever, because of the fact that this withdrawing of life support treatment everybody is frightened about. And they don't have palliative care, facilities where the patient can be then, moved with the tube on, but without the ventilator, and taken care of in the wards, rather than sending them out. And, we've heard horrendous stories. But Dhwani, you want to say anything about this, or I can go ahead. Is there anything that you wanted to add to this?
No, I think to reiterate that that kind of practice is unethical and possibly, and certainly medically negligent as well. And this is something that has been confirmed by government panels that have been appointed to inquire into instances like this. So again, there should be no fear about the actual withdrawal of life-sustaining treatment. The fear should be about not providing appropriate care to a person after that kind of withdrawal or withholding has taken place.
Right. Thank you, Dhwani. Rajni, back to you now. Everybody says, I'm so busy, it's so difficult to have these discussions. So can you give, people who are listening some tips? How do you really go about it? You have to unmute yourself. Unmute.
Such an interesting comment, Dr. Nagesh, because, Dr. Rajam Iyer and myself, the two of us are pulmonologists who have an interest in palliative care. Yes. And we were the two people from another specialty who attended a 2-day workshop on cardiology palliative care masterclasses conducted by the Holyoke Medical School along with Manipal. Interestingly, cardiologists came and attended, gave their lectures and left. Nobody stayed for the full 2 days because they are very busy. Clearly, palliative care doctors are not busy, nor are pulmonologists. So I'd like to question that busy part of it. I don't agree with it. I think communication of tough decisions like this should be approached like a procedure. Now, when we're learning a procedure for a neurologist, if it's a lumbar puncture, for a pulmonologist, it's a bronchoscopy, for an intensivist, it's your central lines and permacats. When we start off, we are hesitant, slow, fumble, we take time. We take more time for an emergency procedure than the elective one where everything is beautifully set. Now, if you look at communication of difficult decisions about end of life care or advanced directives as a complex procedure and train yourself like that, I've realized that I can get to that conversation. You might say that the West says that a conversation like this takes an hour and 15 minutes, but I can do a pretty good job in 2, 3, 15-minute sessions. I might just split it up. I will develop my technique, which works for India and my consultation OPD visits thing. Dr. Mani said a very, very important thing about communication. And this is thing it's been tagged as a soft skill. We tend to, so I have a nice new mnemonic for soft, which is self, other, feeling, thinking. We work on the part where we have to give information to the other. We don't work on the receiving and the collaborative part of it very well in our training. And I'm really hoping that the AdCom modules will pursue that, and we'll have this new generation of wonderful doctors who will be skilled at it. And I think Elicit and Fine and all of us will continue to try and shake up our colleagues who are so busy to actually become far more skilled at this procedure. I think we all need to shift towards this a little more. We need to start understanding about what, shared decision-making, supported decision-making. I mentioned about agency for women, agency for people with disabilities, agency for different family structures. All of this is part of being a good doctor today. There is no denying it. Doesn't matter how busy you are. We get our BLS, ACLS certifications done if you're an intensivist. Get your communication certifications or competencies done. This is a life skill, essential life skill. I have to sometimes counsel for DNR in the emergency room as soon as a patient arrives. This might be an ILD patient who I don't know, but I can hear right off this is a process that's going on for a long time. Or I might have a conversation with a patient I have known for 8 years. Emergency versus elective procedure. As a practitioner for the last 10 years, I better have the skills for
Now, I'll move on to this living will that Roop alluded to. Okay. There's always this bogey of it's going to be misused, right? So 2, 3 of us doctors get together and take a muta of the patient and bump that person off. So what would you like to say to people? What is this current situation and what are the safeguards, if I might say, if any, that are there?
This is for me?
Yes, that's for you.
Yeah. One is, as you said rightly, I think this is a bit of a bogey. We can't look at what, it's a purely hypothetical question to imagine how an advanced directive would be misused here in India. Even in the US, where the practice has been around for a while, there are very few cases of advanced directives actually being forged. And in fact, one of them is of the advanced directive being forged to require where the patient wishes have been overridden to say that they want treatment to continue. So as in the misuse can happen both ways. The misuse can happen to cut short someone's life and also to subject them to unnecessary and undesirable treatment. So one, I think the problem with misuse is greatly exaggerated. And second, there are safeguards that we can have in place. One of them, of course, being that you have more than one doctor sign off on this kind of decision so that you have different kinds of opinion and checks and balances as far as possible. Of course, anyone suspicious of any malified intent can always bring the matter to the attention of a hospital ethics committee or, even in extreme circumstances, move the court as well. So again, I think this points to the need to depend not just on the individual integrity of doctors, but to have in place systems and processes at the hospital level that ensure that misuse like this can be detected early and prevented. And finally, yes, you can have ex post facto safeguards also. You can have audits by end of life care committees and strong, again, disciplinary and criminal action for misconduct, which exists for all kinds of professional issues today as well. So it's not as if this is a special kind of abuse that we are anticipating, though of course it's unique in the sense that it is to some sense, in some sense, a life and death situation. But this kind of misuse is what we worry about in regular medical practice also. And for that, we know we need to have a medical profession that's capable of regulating itself better and has a higher standard of ethical integrity. And we need to have a judicial system that also works efficiently and that can ensure that justice will be done or the suitable punishment be meted out to offenders like this, to ensure that incidents like this don't keep happening.
Thank you, Dhwani, for that. I actually wanted to ask you when will we have a good law, but I will desist from that because of lack of time.
Sure.
It'll be your guess is as good as mine. Okay.
It'll be a while.
So finally, we'll ask Rajni to be the one to have the last word. Okay. I just want to ask you, what is a pulmonologist doing? Being interested in palliative care. What neuron blew up in your brain to make you interested in palliative care? Can you wax eloquent? Because this is Roop has been doing some outstanding work, in neurology plus palliative care. Rajam Iyer, even our good friend Dr. Mani. So could you give some nice advice to the neurologists?
I don't know if I can advise. I can share my experiences.
Yes.
Here's the thing. So I think my experience to some extent was very similar. My realization in many ways was very similar to Roop's, in that feeling that, first as a pulmonologist, interventional pulmonologist, intensivist, you're driven by this great josh of doing life-saving procedures, this great adrenaline rush. And then you start, as you practice longer and longer, you have these patients, you're building relationships who have chronic progressive diseases. And you're feeling this sense of failure and competence ki main kuch nahi kar sakti. Roop had a slide which said main kuch nahi kar sakta. Well, I realized that, so when I moved from the US to India after finishing my training, one void that I was feeling was that, I came in the middle of the H1N1 pandemic, and now here we are 10 years later with the COVID pandemic. All the state-of-the-art ventilatory facilities were there in India. As soon as I came back, we were like doing bang, something's better than the ICUs in New York. But when you had chronic progressive diseases, you didn't have the support system of non-cancer palliative care, which was there. There is a structure of non-cancer palliative care there. Once you start realizing your patients need that support and it's not there systemically, then you learn to upskill yourself, because I can't leave my patient's hand at that point and say, I can't do it. No, I have to learn what I have to do to support that patient. Luckily enough, compared to some fields, pulmonology and interventional pulmonology and critical care have embraced this a little faster, just like neurology, because I think the neuropalliative care courses that's done by FINE is amazing. We are probably a little bit behind, but internationally it's far ahead. There is a concept of IPAL ICU, Integrative Palliative Care ICUs. And very recently, the former president of the World Association of Bronchology and Interventional Pulmonology, sent out this call saying that there will be a bunch of interventional pulmonologists who will be interested in palliative pulmonology, palliative intervention. The idea of embracing technology for palliation. If we understand, and now in the COVID era, it's far more relevant, because there was a recent Washington Post article by a Cornell hospitalist intensivist, and she said, we are all palliative care doctors. I start my integrating interventional pulmonology and palliative care talk with a question. My first slide is always, how many palliative care doctors in this room? If I'm lucky, I have 2 hands go up in the audience. By the end of the talk, I ask the same question again, and all the hands go up. I think we are moving towards a world where we do not have enough specialist palliative care doctors. All of us need to upskill ourselves. When my message to the neurologist colleagues is, you have such an important skill in your hands that helps us a lot in the ICU, and that's prognostication. I'll share a personal experience. My brother-in-law received a heart transplant, and unfortunately, 3-4 weeks after that, suddenly had an arrest. I'll be very honest and say that the transplant team and the palliative care team were not skilled enough. And this is the thing, we've brought lung transplant and heart transplant to India, but we've not got transplant liaison, palliative team, psychiatry support yet in India. And the person who helped me the most for helping the family come to the decision of limiting life-sustaining treatment was the neurologist. So the neurologists play a very important role in helping ICUs help families come to that decision. So I think, you've got a lot of power in your hands, and I'm really looking forward to a lot more collaboration with the neurology.
So Rajni, that's a very polite way, but I will convey it a little more crudely. All you neurologists, guys, go and learn palliative care. It's good for you and good for your patient. Okay, I'm going to sign off the panel discussion and hand it back to Roop to take it forward for the question and answer session. And I thank the panelists for being so wonderful and answering to the point and answering extremely well. So thank you, Anand, thank you, Dhwani, and thank you, Rajni. And over to you, Roop.
I think we've run out of time.
In a way, yes, I know, but
Sudhir, are you there? Sudhir? No. So Sudhir is probably, he had to leave at 1 o'clock. So what I'm going to do is, I am going to close this. This was the inaugural Fine Sunday morning webinar. And it's been great. We've had a fair amount of interaction with the panel. I think you sorted out a lot of questions that we needed. I'd also like to thank the speakers who began right at the beginning, Dr. Madhusudanan and Dr. Meshram, and then Rahul Kulkarni, Rajesh Benny for the quiz, Subhash Kaul and Rahul Kulkarni for starting off the first track, and Sudhir actually for encouraging me to take on this job of doing the DNR discussion. I'd like to close by thanking my fellow panel members and the participants who are still here. Bye. See you next Sunday.
Bye. Thank you.
Bye. Bye.
Thank you, everybody.
Bye.